We'll go live in 3 minutes. So thank you again, everyone, for joining, and happy Valentine's Day.
Good afternoon, Dr. Didi. My computer has some problem with video, so I can't open my video. Is it okay?
Yeah,
Sorry.
whatever works. Sure.
Sure. Thank you.
Hi, Didi, can you hear me?
Yeah. Loud and clear.
Thanks. So I'm on then. Hi, Didi.
Hi.
Thank you for the invitation. How are you?
Thanks for joining.
Hi, Delphitri.
Hi, Bhavna.
Hi, Didi. Hi, everyone.
Hello.
Happy
Hi,
Valentine's
Dr.
Day,
Bhavna.
everyone.
Oh, thank you. Same to you.
Hello, Didi.
Hi there.
Hello. Can you hear me?
Yeah.
Yes, sure. But I'm not sure whether I can share my slides with my computer, or I will try, or later, or you can help me.
Give it a go when it's your turn, and if it doesn't work, we have a backup.
Okay. Thank you very much.
Okay. So we'll go live in a minute.
Yes.
It would be great if everyone can open the camera so we can have a nice group photo. Okay, got it. Okay, just 1 minute.
Dr.
Hello,
Didi, I will have to switch off my video. There's a network error, so I won't be able to keep it on for long.
Okay, that's okay. No
Yeah,
worries.
thank you.
Okay, it's time, so we're going live. Hi, everyone, and thanks for joining. We'll wait another few seconds so all the attendees can join, and we'll start with the webinar. Okay, I think we're good to go. So hello, everyone, and thank you for joining us. Welcome to the Adult Ophthalmic Oncology webinar focused on the Asia Pacific region. It's Valentine's Day, and we're sharing a topic that is very close to our hearts. We have a 2.5 hour webinar with 3 sessions: ocular surface tumors, adnexal tumors, and intraocular tumors. I'm joined by my co-moderators, Dr. Ganga Sandar, Dr. Santa Shanavar, and Dr. Rolika Bansal, who will be helping manage the Q&A. The format is straightforward. Each session includes 5 case presentations. Each presentation is 5 minutes, followed by 3 minutes of discussion. For selected cases in each of the sessions, we're also honored to have expert histopathology input from Dr. Sarah Coupland from the UK and Dr. Derek Lian from Singapore, who will provide brief histopathology comments where relevant. I think we're good to go. I wish everyone an enjoyable and educational webinar, and Santosh, over to you.
Thank you, Didi. and Ganga for putting this together. Hi, everyone. Surface tumors are a very important part of the spectrum that we see in Asia Pacific region, and it is appropriate that we start with this particular set of cases. And we have a very eminent expert panel, introduce Dr. Anirban Bahaduri, who was my own fellow earlier, Calcutta, which is in Eastern India. He's an avid bird watcher as well. And the first case will be presented by Dr. Pasara Jongkompong from and the case that is she's going to present would be an interesting diffuse melanocytic. Ready? Yeah. Can you go full screen and start off?
I think
Yes, I'm sorry. I can. I'm going to the full screen, please. Sorry, take a while. Can you see my slide right now?
without screen share, without slideshow.
Yes, but you need to go full screen. Slideshow mode, please.
You go to the very top of the bar.
Yes. So I
at the
can't move it. So sorry. Please still a while.
Dr. Pasara, there will be like a slideshow button on top when you go to the slide, the fifth, the eighth tab on top.
Yes.
That would show slideshow, and then
Okay, let's work. Is it okay right now?
yes, it's perfect.
Okay. So sorry for technical problem. Good afternoon, everyone. Thank you for the opportunity to share this case today. So let's start. A 38-year-old man with 10-year history of pigmented lesion on ocular surface of his right eye. 10 years prior, the patient noticed broad pigmented lesion involving perilimbal area of his right eye. But 1 month prior, the pigmented lesion showed progressive enlargement with eye irritation. He visited ophthalmologist and incisional biopsy was performed. The pathological report revealed malignant melanoma arising from primary acquired melanosis with severe atypia, and he was referred to our hospital for definitive treatment. His past history includes dyslipidemia, control with dietary modification, no history of cutaneous melanoma or skin cancer, and other was unremarkable. The ocular examination reviewed normal vision 20/20 with glasses, and this is what we found in his right eye. Hyperpigmented lesion at the bulbar part of the conjunctiva. We observed the scarring at the superior part, which is the previous incisional biopsy. And also the pigmented lesion extend from superior, temporal, inferior, and also include the nasal part of his eye, sparing only 1 o'clock at 3 o'clock. And We observed the pigment spill over on his corneal epithelium in the superior part. Also, the extension of the pigmented lesion onto the corneal epithelium in the lower part. Gonioscopy was no abnormal angle pigmentation and open 360 degree. No palpable lymphadenopathy was observed. Systemic workup, MRI brain orbit and neck revealed conjunctival mass 2.4 millimeter in thickness. MRI upper abdomen, CT chest, and PET scan reveal no evidence of regional or distant metastasis. And we have prescribed interferon alpha-2b 1 month prior to surgery. And wide excision with 4 millimeter margin followed by double freeze Lothar cryotherapy and amniotic membrane transplantation was done. And this is the pathological report with PAM with moderate atypia free margin. And the C-min score was 3, 1 for each radial spread, vertical spread, and including melanocytic atypia. The pathologist was confirmed with immunohistochemistry of PRAME, and it was negative. And this is the detail of pathological tissue report. And there is no extension into the stroma. So the postoperative course, he complete reepithelialization after 6 weeks with the adjuvant topical interferon alpha-2b for 3 months. No tumor recurrence at 16 months after follow-up. But finally, he developed limbal stem cell deficiency, but the best corrected VA still maintained at 20-25. We plan for auto-SLED if the condition gets worse. And for this case, we would like to discuss about the point of indications of incisional biopsy and the results of the incisional biopsy, because in this case, we see the inconsistent with the previous pathological report of the incisional biopsy. And also, I would like to have the suggestion from the panelists about the location of and surgical techniques involving for incisional biopsy to maximize yield and minimize tumor seeding. And also the role of topical chemotherapy in the case like very extensive conjunctival pigmented lesion that we have to do the surgical procedure. Thank you.
Thank you very much. Nice case. Before we go on to Anirban, would Sarah like to comment? I think melanocytic conjunctival lesions are close to her heart. Sarah?
Thank you very much. Sorry, I didn't mean to jump the gun. With respect to the histology that you showed and the scoring using the C-MIL system, I would have definitely called that a higher grade, and would have actually called it conjunctival melanoma in situ. So I don't think there's any inconsistency between the original pathology report, where you described it being PAM with severe atypia, which is essentially the same as melanoma in situ, to what you showed on the screen. Essentially, you had infiltration of virtually the whole width of the epithelium by the atypical melanocytes, and so yeah, I don't think there's any inconsistency there, and unfortunately, the patient probably in the first biopsy and now in the second biopsy is conjunctival melanoma in situ, or what the WHO now calls a high-grade melanocytic intraepithelial lesion.
Thank you. And
do I comment on this one? It's a very interesting case. We do see quite a lot of these here in London as well. I think the first part you were asking, incisional versus excisional. I think, in your case, we weren't certain there was a melanoma there, but it was certainly suspicious. I think we would have probably done an excisional biopsy of the thickest component, the most suspicious part, and I would have added sort of mapping biopsy samples of the other sort of less worrying looking pigmentation. Because what you don't know is there melanoma elsewhere rather than just one spot that you took out. We tend to use the sort of no-touch technique as much as possible because you don't want to cause any seeding of tumor potentially. And with the question of chemotherapy, so London were a little different to yourselves. The rule of thumb is that we prefer to give 5-FU for squamous disease, CIN, squamous cell carcinoma. And then we give mitomycin either 0.02% or 0.04% for the melanocytic lesions. So if you've got a patient with PAM and severe atypia, but no sign of melanoma, we would still treat you with topical mitomycin. I don't think we'd sort of do that much invasive surgery unnecessarily because of the, as you see with stem cell failure, it's quite a lot of work. So probably our first line, if you've got a diagnosis, would go towards topical chemotherapy rather than extensive surgery unnecessarily. And then you keep watching because, of course, we know there is a significant risk of recurrences and potential tumor development in the future.
Thank you, Amit. Dr. Lim, do you want to? Dr. Lim?
Yes, thank you. Thanks. I just had a
wanted to
question.
connect.
Can you hear me? I just had a question with regard to the use of the topical interferon, Prasad, and if there was any response after the 3 months that you initially tried it.
Previously, we have only 1 month preoperatively, but we didn't observe any change of the pigmentation. So at first, because the pathological report from the first times is malignant melanoma, so we kind of very afraid of like we have to excise all of them. Yeah, so that's why we decided to do the en bloc of the deletion out of them. But as Professor Amit said, like it's very invasive and also cause limbal stem cell deficiency. And we have already discussed with the patients, and the patients also accept about this. And so I also would like to have an idea from the panelists. How can we manage this case in your opinion? And I have got some from Dr. Amit. Yeah, and how about your opinion about my case?
Oh yeah. So I just wanted to make that comment and maybe see if other people had any experience, because I have had a few cases that have been responsive to topical interferon, melanocytic tumors, and typically the longer periods of treatment, so out to like 12 or 14 months. So I just wondered if anyone else has seen that kind of response, because I wasn't expecting that, but now I have had a few cases.
Thank you, Dr. Lim. Anirban, do you have anything to comment, or do you want to sum up the case? Is Dr. Badri logged in?
I think he's having some internet connection issues. He just texted me.
All right.
Yes.
All right. So can we move on to the next case then? The expert for the next case would be Dr. Amit Arora, who just now spoke about this particular case as well. He joins us from Moorfields Eye Hospital, London, and he specializes in ophthalmic oncology. The case will be presented by Dr. Saida Ruhi Mateen from LV Prasad Eye Institute, Hyderabad, India.
Hello, am I audible?
Yes, Dr. Ruhi.
Yeah.
Dr.
Yes.
Saida, sorry.
Ruhi is fine. Ruhi works. Yeah. Okay, so I'll be beginning. Hello, everyone. I'm Ruhi Mateen, and on behalf of Operational Eyesight Universal Institute, LV Prasad Eye Institute, India, I will be presenting a case of a masquerading red eye. Without further ado, let's begin. Yeah. We have a 49-year-old male patient who presented to us with a history of redness and swelling of the left eye since 3 months, which was gradually progressive. He had a history of psoriasis and was diagnosed elsewhere as having psoriatic-induced iridocyclitis and was treated with methotrexate and deflazacort by the rheumatologist. So this was his presentation with a visual acuity of 20/40. We see an elevated tender nodule in the temporal area of the left eye. Extraocular motility was full and free. The decrease in the vision was explained by a macular scar on fundus examination. His right eye examination was uneventful. So this patient was diagnosed to have a nodular episcleritis and was managed in the UVA clinic with topical steroids. Now he presents to us 1 month later, where we see that the congestion has decreased, but the nodular swelling is still persistent. So at this point, this patient was referred to the oncology clinic, where we went ahead and did an anterior segment OCT. We see a mild thickening and a hyperreflectivity of the epithelium, and there is a subepithelial mass lesion which is noted. Ultrasound by microscopy reveals that the sclera at this point of time is spared. So this patient was planned for an incisional biopsy. Incisional, this is a 40x image. So the microphotograph is showing a spindle cell lesion arranged in fascicles and bundles having spindle nuclei, vesicular chromatin with pleomorphism and brisk mitotic activity. Here the Ki-67 index was 20% and the diagnosis of a leiomyosarcoma was made. It was SMA positive with desmin being focally positive. We went ahead and did a CT orbit to rule out any orbital involvement, so the lesion was limited to the ocular surface with no regional lymphadenopathy. So at this point, we decided that we would go ahead with a conjunctival wide excision biopsy using the no-touch technique and a triple freeze-thaw cryotherapy to the margins, along with surface reconstruction with the amniotic membrane graft. So the histopathological diagnosis was of a leiomyosarcoma. The margins and the base was negative for any malignancy, and a whole body PET CT was negative for any systemic spread. So our confirmatory diagnosis was a primary conjunctival leiomyosarcoma. Given the aggressive nature of the disease and a discussion in the tumor board, a plaque brachytherapy was performed using a round ruthenium plaque of 12.8 mm or 2024 series with a depth of 2 millimeters. So this is 6-month post-excisional biopsy. We see that our patient is doing well. There's a pseudopterygium with a mild tissue drag. But look here, 8 months later, we see that now the limbal scarring has increased a bit. There are areas of intrinsic vascularity, and we see some elevation as well. The anterior segment OCT reveals an abrupt transition of the normal elevated subconjunctival nodule. So we decided to go ahead and again do a repeat incisional biopsy. And while we awaited the biopsy results, we see that the tumor has progressed rapidly within the next 2 to 3 weeks. And this time, the histopathology confirmed that this was a recurrence of a leiomyosarcoma, and the Ki-67 index has jumped from 20 to 40%. We went ahead and did a UBM, and this time the sclera was involved as well. So at this point, we had 2 options with us, either an extended enucleation or an excentration, a lid-sparing excentration. So we gave the patient both the options, explaining him the aggressive nature of the lesion, and the patient wanted an orbital excentration as he did not want to take any risks. So then we went ahead and did a left eye lid-sparing orbital excentration. This patient is now planned for an orbital prosthesis and was asked to get a repeat whole body PET CT, which is awaited. So to summarize, initially diagnosed as a nodular episcleritis, incisional biopsy revealed it to be a conjunct leiomyosarcoma, and when we went ahead and did an excisional biopsy followed by a plaque brachytherapy. He was doing fine 6 months post-excision, but a recurrence was noted after 8 months, and eventually we had to do an orbital excision for this patient. So these are the HPE samples, HPE image of the excentrated specimen, which shows the involvement of the upper 1/3 of the scleral fibers. The cornea was involved and the angle was spared. So our take-home message is that these are rare, aggressive, smooth muscle mesenchymal malignancies, which present as non-pigmented limbal interpalpable nodular lesions with smooth surface, prominent vascularity, and feeder vessels. It is associated with persistent redness, pain and irritation, and rapid growth. Untreated primary lesions usually spare the sclera. So histopathology is a diagnostic cornerstone, and prognosis is guarded with a high risk of local recurrence. Thank you.
Well, thank you very much. It's a very rare condition. I mean, most of these soft tissue
Thank you,
sarcomas.
Ruhi. Very interesting case, a rare presentation of leiomyosarcoma, of course. I was just wondering if the initial plaque that you...
Dr. Hunawar, we lost your voice.
Go ahead, Amit. Amit, you can go ahead,
Please
please.
repeat it.
Dr. Ahmed, please go ahead. I think there is a lag over here.
Yeah, no problem. So, as Santosh was saying, it's a very rare condition. Most these soft tissue sarcomas are found in the rest of the body. They rarely occur in the eye, and if they do, it's generally orbital. So I think there's only a dozen or so reported cases of conjunctival disease. I don't think I've ever seen one myself. The question I would have first is, what would be the sort of differential diagnosis? You know, these kind of patients who appear with a inflamed nodular lesion. If I was asking.
So initially, initially it was considered to be a nodular episcleritis and anterior scleritis, given the inflammation and the history of psoriasis. So that was the first differential on our mind. And the next we thought it could be a OSSM, but then ASOCT revealed that, you know, there is something subepithelial rather than more of an epithelial involvement. So these were our top differentials.
Okay, yeah. Do you think there's a role for any kind of systemic treatment for these conditions, because it's so rare?
So it being so aggressive, we would not really go for it, because if you see the second involvement where the recurrence had, within a span of 2 to 3 weeks, the tumor grew massively. So at that point, we decided that, and this disease is pretty aggressive, so it's very difficult to treat it with just conservative management.
I mean, there have been the odd case where they couldn't do curative surgery, so they've been using sort of systemic chemotherapy, but it's not really curative. When he had the recurrence, I suppose I might have suggested it'd be better having another wide excision biopsy rather than an incisional again, because you'd have to be highly suspicious that this was just a recurrence. It's a rare, and the other interesting thing I think was this issue of scleral invasion, because it said these tumors do not spread through sclera unless the patient has already had surgery. So it makes you wonder.
Exactly. So the first presentation, there was no scleral invasion, but the second time it recurred, there was a scleral invasion.
Was that because of having had one operation before? That was the link. And the last thing I'd note is the role of immunosuppression, because it's been said this is more common in sort of HIV disease, immunosuppressed patients, etc. So he has been on methotrexate for his psoriasis.
Yes.
Maybe
yes, he has been. could be, that possibly could have a role, but we stopped his immunosuppression the moment we got our when he presented to an oncology clinic. We had stopped all forms of immunosuppression by then, and we tried to treat with just excision surgical management, and we tried to see whether that could improve his prognosis, but unfortunately he presented with a recurrence. So because we stopped all the immunosuppressions when he presented to us.
Okay, so it may well be a sort of an important cofactor in these patients, but it's such a rare condition. So he's unfortunate, but you're lucky to have seen one.
So
Thank you so much.
I'd just like to quickly add to that. I agree, exceptionally rare. I think it's important that such a lesion is when you make the diagnosis, you are excluding lots and lots of other options, and so probably an extensive immunohistochemistry panel would have to be undertaken to exclude, for example, spindle cell squamous cell carcinoma, which can be also such as an aggressive subtype. But anyway, that's probably what has been undertaken. I have had one case of a metastatic leiomyosarcoma to the conjunctiva, which, as you perhaps were indicating, Amit, you have to obviously exclude a primary elsewhere, spreading to the conjunctiva, which can bizarrely occur. And in the case that I'm referring to, the lady had a leiomyosarcoma arising in the lung, which in itself is extremely rare. So, but I'll let Derek say something.
Derek, you
I
wanted to
think we have a question
Yes, thank you.
for Ruhi, and Dr. Seema Sen wanted to ask if STAT6 and CD34 were done.
No, they were not done.
So that's important for ruling out a different type of tumor.
Dr. Derek. Yeah.
Yes, I was just going to echo whatever Dr. Sarah has mentioned. I think the epicenter of the tumor does not look like a place where spindles, soft tissue, smooth muscle normally comes from. So definitely a spindle cell carcinoma needs to be considered, and those tumors can also be positive for SMA, for smooth muscle actin. Usually, when we make a diagnosis of leiomyosarcoma, we look for two very strong smooth muscle markers, and I heard that for you, Desmond was only focally positive, so perhaps another smooth muscle stain, Caldesmon, should have been done to cement the diagnosis of a leiomyosarcoma.
Thank you so much for the discussion. I was only wondering if the size of the plaque that was used was adequate, because we have had one other case of similar nature where plaque actually worked beautifully well. We gave 6,000 centigrade of radiation to the scleral base, and the patient fortunately hasn't recurred. It's about 5 years of follow-up. So the size of the plaque is important, and the margins that you need to cover beyond the detected edge of the lesion, at least 2 millimeter clear margins, perhaps is important.
And the size
Can we
we
go on to the
used
next
was
case then?
12.8 with 6,000 centigrade as the dose.
All right. So we go on to the next set of cases. The case will be discussed by Dr. Akshay Nair, young ocular oncologist who shines very bright, and just like his sense of humor. He's from Advanced Eye Hospital and Institute in Mumbai, India. And he is going to discuss the case, which will be presented by Dr. Delfiti Lufti from Surabaya, Indonesia. The title of the case is A Long Journey of Diffuse Ocular Surface Lesions. Delfiti, you can share your screen.
Yes, that's true. Is my voice audible? Because it's very heavy rain here in Surabaya.
Yeah, you're fine. Yes,
Yeah.
we can hear you.
Good afternoon, everybody. I am Delfitri from Surabaya, Indonesia. And thank you, Didi, Dr. Daga, and Dr. Santos for giving me opportunity to share this case. This is the case about the long journey of diffuse ocular surface lesion. So the history is about 80-year-old male. He came to us with progressive blurred vision in his right eye for 2 years and also slowly growing with lesion in his right eye for 2 years. He had a history of right eye cataract surgery a year before the symptoms. He had no history of tumor. He smoked and also living in rural area. So this is from the clinical examination on July 2024, the visual acuity on the right eye hand movement with the normal limit of ocular motility. So we can see here in the ocular surface, there are diffuse gelatinous corneal surface mass lesion involve more than 3 quadrants of the corneal surface with feeder vessel. We also perform OCT anterior for this case, and we can see that there is thickened epithelium and also abrupt transition from normal to abnormal tissue. So the presumptive diagnosis for this case is ocular surface squamous neoplasia with differential diagnosis conjunctival intraepithelial neoplasia and also squamous cell carcinoma. For these cases, we perform the cryotherapy with double crystal, for 3 quadrant, and we can see that 3 days after the cryotherapy, there is a decrease of the diffuse corneal lesion, and you can see the pupil right now. And we give the addition with the topical NMC 0.04 4 times daily, 4 days a week for 4 weeks with 2 weeks off, treatment-free interval. So totally is 6 weeks. So we have a picture from 1 day after 2 second cycle topical MMC, and this is the picture after 1 day after 4th cycle of MMC. So we also have a OCT anterior for the follow-up, too bad we only have like the OCT after 2 cycle of MMC, and we can see that there is a decrease of thicken of the epithelium. So we follow the patient until 6-month follow-up. So this is the beginning of the patient, and after 6 months, the visual acuity is 6/12, and then no residual, no recurrency mass, and this is the clinical picture of the patient after 6-month follow-up. So I learned that not only surgical can heal the patient with the ocular oncology, but I have some question for the panelist question. The first one, is there any other treatment option to remove the lesion? And so surgery in this case, especially be done at the first presentation. And then is a cytology impression or maybe incisional biopsy of the lesion necessary to establish the diagnosis? Because as we know that ocular surface squamous neoplasia is also clinical diagnosis, and they said that with OCT anterior we can perform the biopsy with the optical biopsy. And the last discussion is at the status right now, what should be done to follow up on the recurrence? Is there still a possibility for metastasis? Thank you, and looking forward for the discussion.
Thank you, Delphitri. I think that was a great case, and especially with the final follow-up, it's really a well-managed case. I think I could answer on behalf at least the first and second questions we could club together. So for a case that looks as classically as much as this case would be to be an OSSN, I think and additionally you've done the OCT, which confirms the thickened epithelium with the abrupt transition. That would be presumptive enough for you to go ahead with medical management, and I would not see the need for us to always perform a biopsy in these cases to confirm the diagnosis. I was curious about how you started with cryotherapy initially before medical management.
Actually, we discussed with the patient, because if we want to perform the cryotherapy, we should perform this GA for this patient. And this patient is old enough, it's 80-year-old male and have like hypertension and diabetic, and it's difficult for us to prepare for the surgery. So that's why after discussion with the family, we're trying to perform a non-surgery first for this patient.
Right. And well, amongst other options, I noticed you use mitomycin C was used. In immunocompetent patients, you also have the alternative option of starting with interferon in these cases, but the response was very good. I think to the other question that you asked about the possibility of metastasis in this case, I think given that there's a 6-month follow-up with no recurrence, it's important at primary presentation to assess if there's any lymphadenopathy, the preauricular nodes and the submandibular nodes, etc. But I think high-risk features, of course, those are histological features that we see, and if there's true stromal invasion and systemic risk factors like immunocompromised patients, those are at higher risk for metastasis. Given this degree of resolution at 6 months, the risk of metastasis is probably very low, and you just wait and watch with regular follow-ups. I think any of the panelists would like to add any more points.
To perform like systemic evaluation, systemic follow-up for this patient for the metastasis disease.
No, I'd look for primary recurrence before systemic metastasis in these cases.
If at all, you could do a clinical evaluation to look for regional lymphadenopathy, and then for larger diffuse tumors, you could consider head and neck PET scan. That's about it. Baseline. Amit?
I would say, well, I always prefer to have a biopsy before doing any treatment, even an incisional biopsy, just so you know what you're dealing with. We've had the odd case where, clinically they look like little squamous papillomas, quite harmless, or less, you think it's CIN. You've done the biopsy and it's come back as being more aggressive than you realized. So I would always prefer to do a biopsy first, so you know what you're dealing with. The second is actually in England, we can't get interferon anymore ever since the pandemic for various reasons. So you're all fortunate that you can still get it. I always found it was an excellent drug for the sort of low-grade OSSN patients. It's quite gentle, low in side effects, relatively cheap. And the only downside is you have to take it for several months, at least 3 months of treatment 4 times a day. But unfortunately, we can't get it anymore. So all these patients would have 5-FU now.
Sarah, you wanted to go?
Just want to make a comment. Thanks very much, Amit. By making that comment, you're keeping me employed. Pathologists aren't going to be become extinct. So no, I agree that there are caveats to doing cytological impressions as well, because obviously the impressions you only would receive the most superficial cells of the lesion, and you may not be able to pick up, that may not be representative, may not pick up the atypia, and it may also not demonstrate, you can't demonstrate because of the sample that's been sent, any evidence of invasion. So a biopsy is actually the only way you can demonstrate that. And yes, I agree with the optical imaging, it's fantastic with the OCT, but I still think that it cannot differentiate different subtypes of tumors. It can't differentiate, for example, a sebaceous carcinoma from a squamous cell carcinoma. So I think there is still a point in doing a biopsy.
Thank you, Sarah. Can we move on to the next case then? Next on the panel is Dr. Devjyoti Tripathi, consultant in ophthalmic oncology from LV Prasad Eye Institute in Bhubaneswar, India. The case will be presented by Dr. Mutmainah Mahyuddin from Cipto Mangunkusumo National General Hospital, Jakarta, Indonesia. And the case would be therapeutic challenge to ocular surface squamous neoplasia associated with xeroderma pigmentosa.
Thank you, Dr. Santos. Let me share my slides.
Yes.
Yeah, can you see the slide?
Yes.
Okay, thank you. Hello, everyone. It's a pleasure to be here. I sincerely thank Dr. Ganga and all the organizers in this webinar for the opportunity. My name is Mutmainah Mahyuddin, also from Indonesia, and I'd like to share with you a case of ocular surface SCC, a pathology that we usually see in adult patients, but this case is in a young girl associated with xeroderma pigmentosum. I have nothing to disclose. So the case is 12-year-old girl with a 4-year history of progressively enlarging whitish lesion in the middle of her right eye, accompanied with overall continuing redness despite the over-the-counter eye drops that she is given. She had widespread patchy pigmented skin lesions since 8 months of age, but never seek any prior treatment. No other member of her family is in similar skin condition. So when we first saw her in the clinic, we noticed and extending to conjunctiva.
The age of the lesion is indistinguishable, and there was obvious feeder vessels and overall hyperemia in the conjunctiva as seen in the picture. The visual acuity was hand movement, and what we see in skin was a case of xeroderma pigmentosum. On the anterior OCT, we can see that the lesion is predominantly confined to the epithelial layer, with no evidence of stromal invasion as seen in the arrow. So we did wide excision, really trying hard not to touch the tumor, with additional cryotherapy on the edges, and then covered the cornea with amnion membrane transplantation. As we see here in the slide, the tumor is arranged in a solid pattern composed with malignant squamous cells with keratin pearl formation, as shown in the white arrows are among them. And the pathologist concluded it as well-differentiated keratinizing squamous cell carcinoma with no evidence of lymphovascular invasion. So post-operatively, what we noticed was the wound patients. Although visual acuity is improved very much to 6/18, even after 1 month, we still see inflammation is obviously there despite the anti-inflammatory medication. The continuous redness and watery were the ones that was most disturbing for the patient, especially she was still at school as a student. So around 2 months after surgery, we also noticed right submandibular lymph node enlargement, and then we consulted her to pediatric oncology department, who then gave her 13 cycles of systemic chemotherapy with bleomycin methotrexate. So in this case, usually we gave mitomycin C as adjunctive topical chemotherapy, but we didn't regarding the wound healing process in this patient. 1 year after surgery, we can see the cornea mostly clear, but there was lower lid entropion and corneal ciliary touch present, and entropion correction surgery was performed. So 3 years after surgery, the visual acuity remains stable in 6 with neovascularization. So fortunately, there was no mass recurrence or nodal or organ metastasis observed in the screening. So here she was when she came to us firstly, and then and below, she is now 3 years later. So as we know, XP is a rare autosomal recessive genetic disorder with an extreme sensitivity to UV radiation caused by impaired ability to repair damaged DNA that often leads to delayed wound healing. While SCC, as we know, predominantly affect older adults in later decade of life. So in patients with XP, SCC tends to occur at a markedly younger age, often exhibiting aggressive behavior with high recurrence rate and with impaired epithelial healing. So in this case, primary or adjuvant topical chemotherapeutic agent is not considered due to its nature of delayed wound healing. And adjuvant chemotherapy with bleomycin and methotrexate was considered in this patient for uses DNA strand breaks and is effective against SCC, particularly in cutaneous and mucosal lesions common in XP patients. And methotrexate inhibits DNA synthesis via dehydrofolate reductase inhibition, effective in epithelial malignancies, including SCC. So some points for discussion, maybe delayed wound healing was a major challenge in this case. Any experience maybe from the panelists with wound healing in XP patients, and what would you do differently? Is there anything that we could do maybe to prevent recurrence in the tumor growth or in the fellow eye regarding the risk factor in these patients? And maybe any comments on adjuvant systemic chemotherapy in SCC? So that's all for me. Thank you for your attention.
Thank you so much. Devjyoti, do you have any comments?
Thank you, Dr. Mahyuddin. That's a very nicely managed case. So following up on the discussion points that you just mentioned, I would qualify the first question a little bit more, and there are so many experts here on the panel. I would ask them, would you have done anything differently? For example, we now have different drugs that we can use as topical therapy. Would you consider them as an alternative rather than going in for primary surgery right at the outset?
So we don't have interferon alpha, and also in our hospital we don't have 5-fluorouracil. So mitomycin C is the only agent for topical chemotherapy that we have. So unfortunately, with the XP condition in this patient, we didn't consider that option because we were really afraid of the wound healing after the MMC medication.
Any of the other experts, what would you have done in your practice? There are so many experienced people here.
Personally, I think the surgery is the right thing to do. I wouldn't want to treat a carcinoma with eye drops alone.
Well, this patient had a history of this lesion for 4 years, if I remember correctly. That's what was mentioned in the presentation. So that's a pretty long time. But would you still consider topical treatment for something that presents with a much shorter duration of onset? We know that these patients keep on coming back with multiple recurrences, and the ocular surface scarring is so extensive when you keep on repeatedly operating on the surface again and again, because you have to do surgery for every recurrence that occurs, and it progressively becomes worse. So would you consider at least sort of chemo reducing the tumor before doing surgery? Is that good enough to put into regular practice?
Yes, I think I would want to get the one original biopsy at presentation. So as Sarah was saying, so you know what you're dealing with, but then subsequently, yes, I think first line I would start them on chemo reduction and see if that'll settle the lesion down and try and save multiple operations. But I always personally always prefer the first time you present. That's the time you want to be doing a biopsy. And I need to know what this is before you start giving drops.
Yeah, the second point that was put up for discussion, unfortunately, we do not have any good way of prevention of future occurrences of these tumors in these patients, because as we all know, it happens due to a DNA repair damage that could not be put right because of lack of certain mechanisms that are missing in these patients. So there's no way we can prevent the lesions from coming on. And of course, these patients, depending on the kind of complementation group that they belong to, have risks for multiple different other tumors, for neurodegenerative disease later on in life. And they have to be constantly kept on follow-up lifelong. So that's the approach we adopt with these patients, and they are for sure a challenging set of patients to deal with. Thank you, Dr. Rao.
Thank you so much, Devjyoti. We have one way of trying to prevent OSSN in xeroderma pigmentosum, that is long-term prophylactic use of interferon alpha-2b once a day dose for indefinite period. That helps reduce the rate of local tumor recurrence or new tumors cropping up. So that's something that we could try. And is there any other comment? Swati, you wanted to comment?
Yes, thanks, Dr. Honavar. Yeah, I think I just had a comment on starting topical medication for these patients. I think there are two challenges in this subset of patients. One is most of them have photophobia, and second is most of them are children, obviously. So it's very difficult to even monitor if they're having any response to medical treatment. So I generally do not prefer to start medical treatment in children with XP.
We also have a question from Dr. Ganga. Dr. Honavar, would you like me to mention that?
Ganga? Yeah, please do that.
Dr. Gangadhar Sundar has answered, how often have you all seen multiple neoplasms concurrently, squamous cell, basal cell plus minus melanoma in XP patients? What then? Would
All
anybody
three can
from the
happen,
panel?
but not together. Not together. I haven't seen anything together, but there are situations when the pathologist reports these as basosquamous neoplasia, so with features of both. So that's something that can happen. But yes, we have had patients with xeroderma pigmentosum with squamous cell carcinoma, basal cell carcinoma, and melanoma, but not at the same time.
Right. Thank you. We also have a Q&A from Dr. Arianto based on the previous case by Dr. Delfitri. And Dr. Arianto asks that we have had a case of like Dr. Delfitri, and if we do the same thing like Dr. Amit said, incisional biopsy first, then is it possible that the lesion will become bigger and more malignant than before? And if that happens, would cryotherapy be a better option? So this is open to the panelists. Maybe Dr. Amit can take that up.
I'll have to go back and look at the question again. Hold on. So,
Like after incisional biopsy, does the lesion become bigger and more malignant, and would cryo help?
personally, I don't think so. I can't say I've seen, top of my head, I can't think of patients where in these cases it's got worse by doing the biopsy. I think the risk is more that you may be under-treating or over-treating a case without a biopsy rather than the risk of the surgery itself. I think with all incisional biopsies, the issue tends to be seeding. So we always say to the local ophthalmologists, if they've got a suspicious lesion on the conjunctiva they're worried about, do not do incisional biopsies before sending the patient to us, because I'd rather we did it if we were going to. But I don't think generally as a rule you're making anything worse apart from the risk of seeding. So you've got to be very good at your technique.
I agree with what you've just said, Amit. And I mean, if there's any hint that it could be melanoma, then certainly an incisional biopsy is contradicted. So I think a referral to a specialist center such that then and preferably an excisional biopsy would be then performed.
Right.
Thank you, Sarah. We move on to the next set of cases. Purnima Rajkarnikar Stapit from Tilganga Institute, Kathmandu, Nepal is the expert, and the case will be presented by Dr. Farnaz Khan from Center for Sight, Hyderabad, India. This will be a refractory OSSM.
Hi, hello, and a very good evening to one and all. So I'm Dr. Farnaz, and let me tell you a story of resilience of the ocular surface tumor and the ocular oncologist. So an elderly gentleman in the 6th decade presented to us with recurrent redness in the right eye since 4 months, already biopsy proven elsewhere 2 months back to be ocular surface squamous neoplasia, and he was initiated on topical chemotherapy with 0.04 mitomycin, which he was using almost a week back. So the visual acuity in both the eyes was 6/6, and there was a nodular solid lesion with the epicenter at the limbus and associated limitation in dextroversion. And the slit lamp evaluation of the right eye showed this lesion, which was involving 7 clock hours, and along with intrinsic vascularity, feeder vessels, rose Bengal stain being positive, and scleral fixity. Ultrasound biomicroscopy was also done, which showed a 4 clock hour involvement with maximum episcleral extent of 1.5 millimeters and radial extent of 6.5 millimeters. Anterior segment OCT showed typical features of OSSN with scleral invasion. MRI was also suggestive of lateral rectus involvement up to 3 millimeters from the insertion. So with the aforementioned, the treatment options included extended enucleation, exentration in view of muscle infiltration, and chemoradiation. However, owing to our prior experience, we decided to proceed with the excision of the tumor followed by plaque brachytherapy in the same sitting. So this video demonstrates the excision of the entire lesion, inclusive of the lateral rectus involvement, following all the oncological principles, and plaque brachytherapy was done with a tumor apex dose of 6,000 centigrade and 3 millimeters depth, covering 6 to 11 o'clock first, followed by rotation to 9 to 2 o'clock, and then 4 to 8 o'clock. And during plaque removal, edge double freeze cryotherapy, lateral rectus reinsertion, and followed by ocular reconstruction with amniotic membrane and glue and symblepharon ring suture tarsography was done. So plaque brachytherapy, which was done for the base in 3 rotations, is shown in the pictorial representation here. Histopathological evaluation confirmed OSSN with base involvement, loss of continuity of the basement membrane, tumor infiltrating throughout the stroma, involving the base with squamoid cells and keratin whorls. Margins which were sent separately were free of tumor. So now the patient was doing well, and this is the 6 months post-op picture. But at 9 months post-op period, there was a recurrence which was noted at the superior edge with scleral fixity. So we went ahead with excision again with plaque brachytherapy and tumor apex dose of 6,000 centigrade for 2 millimeters thickness. The patient was again doing well for 4 months until he had a second recurrence at the same time. We went ahead again with excision and plaque brachytherapy, this time with 6,500 centigrade and 2 millimeters thickness. However, there was no regional lymphadenopathy and PET-CT was negative as well. Following this, he was very well until 8 months, and then we had a surprise. Suddenly, the visual acuity dropped to 6/60 with intense anterior chamber inflammation, NS2 cataract because of the age, neovascularization of iris, and the intraocular pressure was 32 millimeters of mercury and thereby neovascular glaucoma. However, there was no evidence of local tumor recurrence. Anterior chamber angle, ciliary body on slit lamp gonioscopy, ultrasound biomicroscopy were all well. A normal posterior segment. To confirm, we did a fundus fluorescent angiography, which also was normal. After extensive literature review, we decided to proceed with 3 injections of intravitreal anti-VEGF for the neovascular glaucoma, probably due to anterior segment ischemia, and followed by that, once there was resolution, safety enhanced cataract surgery was done, and the patient's vision improved dramatically to 6/9. So ultimately, his last follow-up, which was almost currently 3 to 4 months back, after a 4.5 years of follow-up, his vision is still very well, until 6/9, and anterior segment evaluation showed no local tumor recurrence, no regional lymphadenopathy as well. So aggressive management of recurrent OSSN with surgery, plaque brachytherapy, and local tumor control, while intravitreal anti-VEGF for secondary complications like neovascular glaucoma can ultimately lead to successful outcomes. We started with recurrence, but we ended with globe salvage, vision salvage, and no local tumor recurrence. And that's how we salvage the unsalvageable, and that's what resilience was all about. Thanks a lot.
Thank you, Farnaz. That was
good.
Go ahead. Thank you, Farnaz. The tumor was not only resilient, the surgeon was also not giving up on the case. So this is an excellently managed case of ocular surface tumor, showcasing an innovative and well-executed surgical technique by Dr. Hunavar sir, as usual. And it goes beyond the textbook protocol based of management of OSS, and where it is recommended that if the tumor reaches the fornix or acanthus, then it is seen to cross the septum on imaging, then we cannot salvage the eye, because once the anterior segment tumor crosses septum, we have been studying that it invades the orbit, and it is impossible to get the surgically clear margin in the malignant cases once it reaches the orbit. Except for in the benign cases, well encapsulated cases, we can get the clear margin. But in this case, in the MRI films also, it seems that tumor has crossed the septum, and you have mentioned that the lateral rectus was also involved. However, here triple rotation plaque, which is a novel technique as far as I know, did the magic and killed the remaining dysplastic cells. Hence was able to save the globe with the good vision. So with the close observation and second recurrences was also taken care of. So it seems that the number of plaque the patient gets, it doesn't matter much, because we have only seen the patient getting plaque at least once or maybe twice, but not more than that. And it reminded me of one case, a young male with OSSN, previously excised with prio and then 5FU as well, and came with the recurrence not on the bulbar. Previously, it was in the nasal bulbar conjunctiva, but this time recurrence was not on the bulbar, but on the upper tarsal conjunctiva, which I diagnosed after I saw that upper lid seemed a bit bulky and there was a mild ptosis. And when I saw it had reached the upper fornix, and after confirming as an invasive squamous cell carcinoma on MAP biopsy, I started on 5FU, hesitant on doing exenteration. but it kept on increasing and spreading across the whole of the tarsus and had to do exentration finally. So I just thought maybe the plaque would have also helped him in this case. And is it advisable to place the plaque on the eyeball to cure the tarsal conjunctival lesion? Sir, Dr. Munawar, I would like to start the discussion with.
There is no design of plaque to treat the eyelids currently. We are working on a conformal plaque brachytherapy design, which may be able to treat the posterior aspect of the eyelid, the palpebral conjunctiva, and the tarsal conjunctiva, but that design is not ready yet for commercialization.
Santosh, you used the rotational plaque technique to spare the cornea. Was it a 15 millimeter ruthenium CCA? Which plaque was it?
This was a 20 by 16 millimeter ruthenium.
Oh, okay. I mean, you could theoretically use a larger plaque and cover the cornea and include the entire conjunctiva as well.
Yes, that would have been possible if we had a larger plaque, but the size is a limit.
Yeah.
So there's no limit to how many times we can use the plaque in the same eye.
There is, of course, there is a obvious, right. Scleral toxicity is obviously a limitation, but when you, I just give you an example of a choroidal melanoma. Say if you have a 6 millimeter thick choroidal melanoma, you would treat transscleral with ruthenium or iodine plaque brachytherapy. The sclera gets about 120,000 centigrade of radiation. Here, you're treating a 2 millimeter thick and for about 6,000 centigrade. The sclera gets about 12,000 centigrade. Even if you repeat the plaque 2 or 3 times, the cumulative dose the sclera would get would be about 36,000 centigrade. So that is much less than what you would give to sclera in a patient with a uveal melanoma. So scleral melt is something that I haven't seen, only heard about, but I think it's a very rare complication.
We see scleral melt when we treat with plaque for ciliary body melanoma, so for large tumors after several years, but obviously it's not the case.
That's right.
Dr. Munawar, Dr. Abdullah has asked that, do you do LR resection as well in your case?
Right. What we do is our MRI expert tells us how many millimeters of the lateral rectus is involved. And if the lateral rectus involvement is real, then we could get intraoperative frozen section as well to make sure that the lateral rectus involved is completely resected along with the tumor and block. And then we do plaque brachytherapy on the insertion of the lateral rectus, the residual 4 millimeter of lateral rectus after reinserting it with a little bit of recession. Amit, Swati, you had comments.
Yes.
I think our Adnexal colleagues at Moorfields would almost certainly go for an extended enucleation or exenteration, but I think they'd be happy with us trying multiple plaques. I think we get a bit of pushback from our side if we wanted to try this here in London, but it's an incredible idea. With DD, you were saying we don't get many scleral melts in London. I think there are probably only a couple I can think of in the last 20 years. As Berto D'Amato says, the important thing post-plaque is that you have to cover the conjunctiva over the treated area. The biggest risk factor are people where there's retraction of the conjunctiva after the plaque is removed and it leaves bare sclera. And that's the bit that actually will start to show scleral thinning. With sort of normal ruthenium plaque for intraocular tumors, we tend to say about the same, 1,000, 1,200 gray is reasonably safe. Probably 1,500 is safe for sclera. Depends if you're counting surface scleral dose or mid scleral dose, because we do both. But the sclera will, realistically take a lot of radiation. without having significant thinning. I think it's that conjunctival covering that's actually quite important. But it's I think, very interesting idea. But I just don't think our Adnexal colleagues will let us put 3 plaques on it.
All right. Thank you.
Yes. So
Swati, you have a comment?
yes, yeah. Great case for Naz and Dr. Honavar. So I think if I noticed the first picture correctly, it looked like a nodular ulcerative variant where there was already an existing area of thinning that was perilimbal. Is that correct for Naz?
That was the area of prior surgery at the time
Prior
of X-ray.
surgery. Okay. Yeah, because at least like when we see the cases that begin with this picture, they do have this very high chances of recurrence. And when the patient had AC inflammation, did you consider that it could be though there was no tumor on the ocular surface, but did you consider that it could be the intraocular extension?
So from the beginning,
Yes, that
sorry, sir, please go ahead. Sorry, sir.
Good, Farnaz.
From the baseline presentation itself, there was no extension into the cornea as well. So, and the patient was phakic also, ma'am. So the chances, and also even the MRI, there was no involvement of the anterior chamber anytime throughout.
Yeah, I'm just talking
UBM was done.
Yeah, I'm just talking from experience from one of the case. So especially these, though probably this patient never had intraocular extension, but just to mention that probably we should consider when there is AC inflammation in a treated case of OSSN or invasive squamous cell carcinoma, to be specific in this case, especially if it presents as nodular ulcerative variant. After excision as well, they might have these AC cells, and sometimes the UBM might reveal that there is no surface tumor, but there might be thickening that might be present in the area of that scleral thinning where there might be ciliary body thickening, and they might have extension which shows up as AC inflammation. Though I'm sure this patient didn't have, because the patient underwent cataract surgery and is doing well at follow-up, but that is something to be considered.
Yes, ma'am. So during that time, we had gone ahead with ASOCT and UBM as well, and that was all clear.
Thank you. Then if there are no more comments, then we move on to the next segment, and that will be led by Dr. Gangadhar Sundar, and that will be a set of cases of adnexal tumors.
Great. Thanks. Welcome, everybody. We switch gears, and although, yes, we are nitpicking about ocular surface, intraocular, and adnexal, in reality, it's all one continuum. And it's my pleasure to introduce the first speaker from this section, Dr. Ong Se Chuan, a senior resident from National University Hospital, Singapore, which subserves a multiracial population, and the case to be discussed by Dr. Fairuz Manjan Davida, expert ophthalmic oncologist in India, Middle East, and probably China and other parts of the world. Over to you, Se Chuan.
Thank you, Dr. Ganga. Good afternoon, everyone. Thank you for having me here. Today, I'll be presenting a case of a periocular cutaneous carcinoma recurrence with peridural infiltration that we manage in our hospital here. So this is an 83-year-old male Caucasian who was an ex-smoker of more than 50 pack years. Of note, he has extensive past medical history with forehead cutaneous BCC and SCC status post multiple surgeries since the 1980s, with the latest excision biopsy and skin graft being in July 2024. He also had a left brow and forehead benign tumor that was removed in February 2025, complicated by a post-operative surgical site infection. He's a hypertensive and diabetes mellitus, but otherwise he has no other past ocular history. So he presented in September last year with a horizontal binocular diplopia for 4 days that was worse on far than near, with no other constitutional symptoms. Of note, he has hit his head on the back of his car boot a few weeks prior. These were the examination findings. The main finding was that of a left esotropia that was worse on left gaze, as well as a left abduction deficit. There was also extensive forehead and nose hypopigmentation and scarring from previous surgeries and skin graft as seen in the clinical photos here. Visual acuity was otherwise good, optic nerve functions were full, and the anterior and posterior segment examinations were all normal. A CT brain was done by our emergency department colleagues, and it was reported to have this asymmetrical prominence of the left superior ophthalmic vein that was non-specific in nature, but there was otherwise no significant abnormality noted. The patient was admitted in neurology. The impression then was a left isolated 6-nerve palsy, and the plan was for MRI brain orbits with contrast, a lumbar puncture, and a few serologies. These were the MRI scans contrasted. So it was initially reported to have this thickening and enhancement of the bilateral levator palpebrae superioris muscle, with the left more than the right being more enlarged, with mild fat stranding. There was also asymmetrical enhancement along the left superior orbital fissure and apex seen in this top right photo, with no extension into the cavernous sinus. The bottom two photos just shows mild thickening enhancement in the supraorbital soft tissues, as well as the preseptal soft tissues. It was reported that the 6th nerve did not appear enlarged, and the overall findings were suggestive of an inflammatory or infective process. Further progress-wise, the serologies and lumbar punctures were unremarkable, and the patient was managed as left ischemic 6th nerve palsy and discharged with outpatient follow-ups. He was subsequently seen 1 week later by our oculoplastics and neuro-ophthalmology team in the clinic. Of note, the left esotropia angles were larger with a worse A reduction limitation. The left eye saccades appeared hypometric, and the force suction test performed showed no restriction on passive movement, horizontal and vertically, which suggested a paralytic etiology. So we further discussed the scans with radiology after reviewing it themselves, and the enlarged structure at this left supraorbital region, which was initially thought to be the levator palpebral muscle, it actually extended inferiorly towards the left superior extraconal space, and actually on second thought, it was thought to be more of an enlarged nerve, possibly the frontal nerve. The contralateral nerve was also mildly enlarged. So overall, given the history of the prior BCC and SCC at the forehead, these findings are quite concerning of perineural spread, and the patient was offered a left anterior orbitotomy and frontal nerve biopsy. So I'll skip ahead to the point. This is the intra-op video where the left frontal nerve was harvested, performed by Dr. Ganga and his team. Yep. The histopathology came back and confirmed that the left frontal nerve was infiltrated by carcinoma. On immunohistochemistry, there was staining for AE13, MNF116, and 34PE12. The excision margin was also involved. Following a discussion with the reporting pathologist, however, we could not distinguish if it was BCC or SCC infiltration based on the morphology and the immunohistochemistry stains. So further progress for the patient, he was referred back to the original private plastic surgeon for consideration of tissue blocks or foil lesion for further histological confirmation, but the private plastic surgeon said he was not able to perform any more biopsies as there was no suspicious skin lesions remaining. He was reviewed by medical and radiology oncology colleagues. A PET CT scan was done which showed several FDG-avid retroperitoneal lymph nodes for monitoring. And as the last histology provided by the private plastic surgeon was that of a SCC, the advice was to treat it as such, with a keep-in-view biopsy early if there was no response to treatment. However, treatment intent was largely palliative in view of the perineural spread of the disease. The options include radiotherapy at a palliative dose or anti-PD-1 inhibitor, out of which the patient opted for anti-PD-1 tislelizumab. So in summary, this is a cutaneous BCC and SCC with perineural spread in the superior orbit extending to the supraorbital fissure, with a fairly subacute onset presenting with binocular horizontal diplopia with left A reduction deficit in a 3-year-old Caucasian male. Thank you, everyone. And we just have a few discussion questions for the expert panelists. So firstly, what is your experience with perineural spread in facial periocular cutaneous carcinomas? And what are the response rates for immunotherapy in such cases? And lastly, in view of the histology where it's inconclusive, should the tumor not respond to immunotherapy? What are some treatment options for this patient as well? Thank you. And I'd like to pass time over to panelists.
Thank you, Sichuan. Over to you, Fairuz, and I also invite other expert panelists who have a lot of experience with perineural spreads to answer these questions.
Hi, Dr. Ganga. Dr. Chuan, it was an excellent presentation, and I should say that it's a very rare, challenging case, and this has got a lot of scope for discussion here with valuable insights. So considering this patient having multiple SCC, BCC over a long period of time, right from his younger age, have you considered any systemic association or syndromic association in this patient? Was that thought about?
Yeah, syndromic, including Gall and Galls, but he didn't have features of any. And
Okay.
he's nature of the industry, he's been around the world in the shipping industry, marketing industry, plenty of sun exposure in his younger days. That's about it. Yeah.
Right. So arsenic is something which can cause a lot of, BCCs and SCCs and multifocality in, considering this. And initially, I think with the histopathology and the immunohistochemistry, there was kind of a confusion between an SCC and BCC that they couldn't confirm. Right, Dr. Ganga?
That's correct. Yes.
Right. I mean, we have Dr. Sara here. We can also, take her insights into it. So whenever we have to differentiate between a BCC and SCC, actually the critical diagnostic tool in IHC is the BER BER EP4, which actually came negative in this case, and it's usually negative in squamous cell carcinoma. And the CAM 5.2 was also negative, which can also be negative in usually well-differentiated squamous cell carcinoma. So, Dr. Sara, in your experience, would you consider this right from the beginning that without any confusion that it would have been SCC?
So I think Derek should probably also comment. I mean, I guess the differentiation between BCC and SCC is predominantly on the morphology. Whether you see the classic palisading pattern and the retraction artifact of the BCC in the primary tumors, and whereas obviously the SCC, you try often but not always have the squamous eddies within the tumor, so a squamous differentiation. There are differences, as you mentioned, with the immunohistochemistry panel, although we, typically wouldn't perform extensive immuno if the diagnoses are clear. That being said, both of them can spread perivascularly via, around blood vessels and also perineurally, and that has to be documented in the primary report. So that's a part of a minimum data set that has to be included in all reports. With respect to what the immuno which was performed, you can't really differentiate specifically between an SCC and a BCC on the basis of the cytokeratin stains. The BER EP4, which you mentioned, is typically positive in sebaceous cell carcinomas. But there are other markers that you can use to confirm a sebaceous cell carcinoma, which I don't think came into question in this case.
Right.
There are a couple of other markers, such as BCL2, which are classically more positive in basal cell carcinomas, and not in not in SCCs. So a broader panel could be undertaken to see if you could define it more clearly. That being said, as unfortunately, once you've got perineural spread, then it's, as you all know, very difficult to remove completely.
Right. Yeah, so PNI, your question was our experience with PNI in cutaneous SCC and BCC. Well, I don't have an experience and I've not seen it before. In fact, with BCC is much less than 1%. And, in SCC is slightly higher as reported in literature, maybe around 2% to 10%. Still, it's very low. But then having a PNI, which is perineural invasion, is definitely a high risk, especially if it's in the orbit where, there can be a skull-based spread. And being in the superior orbital fissure, I guess, the abduction deficit and initially considering a 6-nerve palsy, that would be the reason. It is considered to be very aggressive and they can have multiple cranial neuropathies, etc. And this is just a beginning that you saw, possibly, if it's not treated aggressively, it can have a skull-based involvement in this particular case. Ideally, I would think that radiation is considered as an adjuvant treatment for these things because it has to be aggressively treatment. And considering the immune checkpoint inhibitor, FDA approved for cutaneous finally considering the diagnosis cutaneous squamous cell carcinoma, it's semiplimab, nivolumab, and pembrolizumab, right? So you went ahead doing tislelizumab, which is usually not globally a standard immune checkpoint inhibitor for SCC. Was there a reason for that?
It's not readily available here because incidence
Okay.
of these malignancies of targeted drugs are not yet available here. Yeah.
Not yet
So we
available
kind of
now.
extrapolate what we have from other neoplasms and
Okay.
known to target this tissue. Yeah, that's it. Yeah.
Right. Yeah. So cutaneous SCC, we all know, the first thing that comes into your mind is semiplimab and pembrolizumab, and it definitely is effective. But I think considering radiation would be the way forward, according to me, we can take opinion from the other expert panelists. They're all here from the global south and the north over here. So yeah, it is aggressive. PNI indicates aggressive SCC, and there is definitely high risk for recurrence, metastasis, and considering this neural invasion in the orbit extending up to the apex for skull-based invasion. Yeah.
Yeah. So in the interest of time, we'll just move on. Although I don't know whether Krishna and Amit would like to comment because you see more Caucasian patients with these. The take-home point was number one, misdiagnosis, oftentimes by physicians, neurologists, ophthalmologists, and the radiologists included, superior ophthalmic vein versus LPS. When we saw the scan the first time, to us it was obvious it's the frontal supraorbital nerves. When we went for the money, the diagnosis, like Sarah Copeland says, tissue. And then at least we had a diagnosis and we are chasing the patient's management.
Yeah, but the surgery was excellent, Dr. Ganga. You could really go inside and take that chunk off, frontal nerve. It's so nice. And thank you for showing the video. Yeah, excellent.
Thank you.
That we
So
have a tissue. Yeah.
thank you all. In the interest of time, we'll move on. We now have the second speaker from Til Ganga Institute, Dr. Diksha Bista, whose case is going to be discussed by that young ophthalmic oncologist from Mumbai, Dr. Akshay Nair.
Thank you, sir. Namaste. First of all, thank you everyone for giving me this wonderful opportunity to present. I'm Dr. Diksha. Okay. So my case is a 64 years female. Okay, is it visible?
Yes, we can see your slides.
Yes, okay, thank you. So my case is a 64 years female who gives a history of swelling of the right eye upper lid since 1 year. It was increased in swelling, the swelling increased since last 1 month. It was associated with mild pain. There was no history of redness, double vision. There's no history of diminution of vision. On her past history, she gave history of surgery done on the same eye 19 years back. However, there were no documentation available. There were no reports available. She was told that the mass was benign and it was all resected. She's a non-smoker, non-alcoholic, and there's no history of any known systemic illness. On examination, her vision was normal. Extraocular motility were full and free on all cardinal gazes. Anterior and post segment were normal. She had actual proptosis of around 2 millimeters on the right eye, and the lymph nodes were not palpable. So looking at the mass was a soft cystic mass, which was present on the subbrow area. It was around 1.5 to 1 centimeter. It was mobile, non-tender, non-adherent to skin, and not adherent to bone. Scar mark was present adjacent to the lateral canthal region, which was because of the prior surgery. So we did a CT scan where we could see a ill-defined lobulated soft tissue density present. It was a heterogeneous attenuated bulging mass, which was seen at the region of lacrimal gland with bony erosions adjacent to the frontal bone. And here we can see also the lateral bone, maybe because of the past surgery where the lateral orbitomy was done or because of the erosions. So with the past history of lacrimal gland mass, as she suggested, and also on CT scan, there were erosions and a very short history of presentation. We suspected a malignant transformation, and then we did surgery. Because the mass was superficial, we did an anteroorbitotomy with subbrow approach, where the cystic mass was resected. The mass was also present deep in the lateral area of the orbit. So 2 mass was excised. One was a cystic mass, which was One was the cystic mass, which was is are you seeing my PowerPoint presentation? Because I can't actually see.
We can see your slide. If your Wi-Fi is good,
Okay.
switch off your video camera.
Okay. Yes, sure, sir. Sure. Okay. So there were two masks. So one was the cystic mass and one was removed from the deep mass, which was cheesy in appearance. And because it was not well defined, we could do only debulking. So this is the post-operative photo of the patient. And then we sent the mass for histopathology examination, where both the mass were submitted and it showed a tumor which composed of ducts and seeds of epithelial cell disposed in a myxoid matrix-rich mesenchymal component. Epithelial cells were mildly pleomorphic and cuboidal in nature, with mild nucleopleomorphism. Fascicles of the spindle-shaped cell were noted as well. So a diagnosis of recurrent pleomorphic adenoma was made, which was negative for malignancy. So we kept the patient on close follow-up. In conclusion, this kind of mass where there is an incomplete resection, excision, or there is violation of the pseudocapsule, and incisional biopsy are done, then it is reported to have a increased risk of recurrence and malignant transformation. Researchers have shown that the recurrence rate of around 3% even if the intact excision is done, and it increases to 32% even if when there is incomplete excision is done, and they are more prone to malignant transformation. As in this case, recurrent mass are mostly multinodular. So there are many nodules of the mass, so it's very difficult to treat, and it can often infiltrate the normal or vital structures as well. So 10% of these mass undergo malignant transformation by 20 years and 20% by 30 years. So we should keep the patient on a very long follow-up. Some multiple recurrences can also develop adenocarcinoma, and the longest interval period in the literature for this metastatic transformation is 60 years. So for these masses, we can either do excision that we did in this case, or we can do a radiotherapy, or even if the orbit it is involving the orbital tissue, then we have to go for exenteration. So it is very hard to explain to this patient that their mass is benign, but it is recurrent, and it can have a malignant transformation in the long run as well. So I wanted to ask our respective panelists about their preferred treatment options and the time to intervene, and also about these remnant masses, because in this case also, we could not remove all the mass. So how do we proceed? We do just the observation, or we go for adjuvant radiotherapy? So this concludes my presentation. Thank you.
Over to you, Akshay.
Dr. Ganga, the discussant for this one would be Dr. Swati Kaliki.
Oh, I'm sorry. Okay, I have a different list. Okay, Swati, perfect. Yes, introducing Dr. Swati Kaliki from Devi Prasad.
Yeah, thanks, Dr. Ganga. A great case, Diksha. So I think this case, definitely the recurrence has happened after 19 years, right? And also if we see the imaging, there are bony changes as well. Though the histopathology, you mentioned that it was given as recurrent pleomorphic adenoma. I mean, we have had cases where these recurrent lesions, of course, they have these very small component of carcinoma which may not be the predominant histopathology of the entire specimen. So I think multiple sections are really required in such cases to make sure that we are not missing a carcinoma, which might form just like, maybe even less than 5% of the entire mass that has been sent to the lab. So I think really the multiple deeper sections are required to conclude that this is truly recurrent pleomorphic adenoma and not carcinoma ex pleomorphic adenoma. Because since this has occurred after 19 years and it is recurrent, it is irregular if you see on the imaging, has bony erosion, which all points towards a malignant transformation. So that's what I would suggest, that maybe you can go back to your pathologist and just request them to do multiple sections. Because that is really going to determine your next plan of treatment, whether you can truly just observe this case or this case requires adjuvant radiotherapy. Because if there is a carcinoma component, obviously you would want to do adjuvant radiotherapy for sure in this case.
Derek or Sarah, pathological comments regarding how often is a malignant focus in a benign pleomorphic adenoma missed, and your experience, please?
I mean, it's how often it's missed. That's a difficult question to answer. I probably have to look back through the literature to determine that. But I agree completely with Swati that the whole lesion has to be embedded, and levels from each of the different paraffin blocks. What's important is to look for to see whether there is a capsulation of the adenoma, and if there's any hint that there is no capsule surrounding the lesion, that you have to look for any evidence of invasion or cellular atypia, and if there is a suggestion that it has undergone a malignant transformation into an invasive carcinoma, then what type? More often it's squamous cell carcinoma. And then again, like we were speaking with the other case, looking for perineural spread. Derek, do you want to add?
The only other point I have to make is I think it's important to have good communication with your pathologist. So if clinically you suspect that it is malignant, you should tell the pathologist, because sometimes, I mean, to us, if we see a pleomorphic adenoma, a lot of our juniors will be very happy and just sign it out and not look anymore. So yeah, you should tell us to be really, really careful.
And potentially, sorry, just to add, once you've removed the lesion and the particular part of the lesion is close to the bone, then mark that part of the tumor with a suture or something, so that it flags to us that this is possibly the area where you might be considering it could be malignant.
Yeah, great. Yeah, and I mean, Santosh, would you do anything different? Number one, and number two, Diksha, if you look at the scan, yes, there's a bony change, but I would dare say that it's probably from a previous marginotomy that was done to excise this lacrimal gland tumor, which is seen as a bony irregularity. And now you know very well that most orbital tumors nowadays, we prefer consciously not to do a marginotomy. First, you don't need it. Number two, you can actually potentially express or expose a bone marrow space in case of a malignant tumor that you're excising, exposing to the systemic circulation. Santosh, your comments on recurrent benign pleomorphic adenomas.
He had to log out, Dr. Sundar, because of his commitment in person.
So anyway, the take-home message is, number one, when you go back this third time, you don't go with an incision biopsy. Try to remove practically everything that you remove. And the new paradigm is these kind of benign tumors where you're doing excision biopsy, please do a post-operative imaging to ensure that you have done a complete removal. If not, go for it. So any further comments? Any questions, Rolika, before we go on to the next case?
No, that's fine. Dr. Abdullah had a question that does eroded bone express the malignant cells if ever there is recurrent pleomorphic adenoma, directed to Dr. Swati, and she has responded to it. Dr. Swati, would you mention it online as well so that everybody...
Yeah, Rolika. So, yeah, I had another comment, but I'll make that after answering this question. As I've already put out, because, and also as Dr. Ganga also mentioned, because there is already a history of previous surgery in this case, it's hard to comment, like, whether the bone irregularity that was seen was influenced by the previous surgery or if it is truly attributed completely to the recurrent tumor. But either ways, if there is some amount of bone erosion that is present in a recurrent case specifically, I would consider, though it may not be like pathognomonic, but I would consider that you should rule out if there is any malignant transformation. Yeah, I just had one additional question to Diksha. So the second specimen that you had that did not harbor any tumor at all, like it was removed in 2 pieces, right?
Yes, ma'am. The first one was a cystic mass that the patient presented with. And then we debunked, because in the CT scan, we could see that there was some mass on just the lateral side of the orbit as well. So we debulked as much as possible. So that is not present in the photo, but it was more than that. So we sent the 2 samples, and both the sample showed to be a pleomorphic adenoma. In both the samples, it was positive to be pleomorphic adenoma only. we specifically wrote about that, and then the pathologist cleared with all the history and all that with the sites given for like both the samples, it was cleared.
Yeah. Yeah, I think as discussed, maybe you can just ask your pathologist to relook at multiple sessions.
Okay, sure.
Great. Thanks all. So let's move on to the third case. Not sure whether it's an orbital case or an ocular surface case. We have Dr. Alexua, who's a mini Jack Rootman, so to speak. He's a clinician, surgeon, and a pathologist himself, who's going to share a very interesting case. And this is where we need the pathologist to give the expert inputs.
Thank you, Dr. Ganga and the organizing committee for this invitation. I'm Dr. Alexua from the Philippines, and I have nothing to disclose. No, so we have a 54-year-old female
Dr. Sua, I'm sorry to interrupt. Can you use the non-presenter view? It's still showing as the presenter view.
I'm sorry.
It will be the three dots at the bottom, the three dots in the circle. When you click on that, it will show you the option of switch presenter view.
Wait. I can have three options.
The three dots in the circle, that will help you switch the presenter view.
I'm sorry. Three dots in the center.
You can try resharing it without the presenter view and it will automatically show up.
While he's doing that, let me introduce the discussant for this case, Dr. Ho Saksa, a very bright young oculoplastic surgeon from Korea, a rising star in the field of orbital oncology. Would you like to?
Yes, the three dots right there. Yes, perfect. Yeah.
Slideshow?
Yeah.
I was thinking, well, can you see the slide?
It logged out, so, Dr. So it logged out. If you can
I'm so
reshare.
sorry. Sorry. Sorry for the glitches.
No problem. That's fine. Till then, maybe we can take a question that was popped up earlier. The question was that in the cases that we had where there was extensive OSSN, it was a question asked earlier by Dr. Afghani, that how about quality of life in the patients who've undergone so many procedures? Like if there's a total excision, like maybe exenteration can be shocking. So maybe if any studies have been done to improve the quality of life. Dr. Gaga, we can take your comment on that.
We have the presentation on, so
Okay,
let's
we
continue.
can, yeah,
Thanks,
sure.
Volga.
Over to you, Dr. Swa. You may start the presentation. We see your slide share.
Okay, I'm so sorry with the technical glitches. So we are presented with a 54-year-old female who sought consult with a hyperpigmented mass on her left eye. History started 10 years prior to consult as a dot-sized flat hyperpigmented lesion on the left temporal bulbar conjunctiva. This was associated with foreign body sensation with no other ocular symptoms. She sought consult and the lesion was excised with no histopathologic evaluation. Post-excision, the patient reported more complete resolution of the symptoms with no other residual lesion. She remained asymptomatic until 3 years prior to consult. There was recurrence of the lesion at the previous excision site and now progressed to twice its original size, which is associated with sharp localized pain. Excision biopsy confirms the diagnosis of conjunctival melanoma. However, there was a residual hyperpigmented area at the surgical site, but no further treatment was done. Histopathology of the conjunctival mass showing malignant melanoma with predominance of your epithelioid cells. 8 months prior to consult, the patient noted rapid enlargement of the residual lesion, now elevated and associated with sharp eye pain. Orbital CT scan revealed a soft tissue mass with pockets of air in the left preceptor region. Patient was then referred to a corneal specialist and was started on topical chemotherapy using 5-fluorouracil, for which the patient completed 3 cycles, but the tumor continued to increase in size with progressive loss of vision. A repeat CT scan showed an increase in the size of the mass with extension to the lateral and inferior aspect of the orbit. Thus, a neoadjuvant radiation therapy prior to extranturation was suggested. 15 cycles of radiation therapy with a total dose of 45 gray, hoping to decrease the tumor size was given. However, there was no change in the size of the mass, and now it's covering the entire cornea. Patient also noted a yellow-colored lesion adjacent to the mass. Due to the persistence of the mass lesion, exenteration was advised due to local tumor control failure. So this is the picture of the exenterated orbit, and we're going to show now the histopathologic features post-radiation therapy on the specimen. So it shows microscopic section corresponding to the yellow overhanging lesion on the clinical picture as shown. And we see here degeneration of your collagen fiber, residual pigments of melanocytic cells, inflammatory cells, as well as vascularization. This is the other side showing the pigmented lesion as shown on the clinical picture. And it typically shows the squamous metaplasia of the surface epithelium, cellular vacuolization, necrosis, as well as your Besire cells. There's a presence of scar and extension of the tumor beyond the Bowman's membrane. Treated melanoma cells exhibit cytoplasmic vacuolization, balloon cell degeneration, and nuclear disruption. There's a lot of neovascularization as well as necrosis in the tumor bed. And these are some of the other effects of radiotherapy, which we are shown here. Muscle atrophy and degeneration of the fibers of the sclera, hyalinization of the blood vessels, as well as occlusion. However, there are also other histopathologic risk factors that we need to consider in our patient. There's a deeper area showing viable tumor, the presence of spindle-shaped cells with hyperchromatic nuclei, some with prominent nucleoli, as well as melanin pigments. And we also note the tumor vertical thickness of more than 2.5 millimeter, which is quite important. There's also positive staining with your HMB45 in the remaining tumor, and the persistence of a high proliferative index as shown with the positive Ki67. We also see the presence of residual tumor, and histologic section of the irradiated scleral bed also show predominance of your radiation fibroblasts. So here we are now faced with a lot of challenges in our patient with these risk factors. Other factors to consider would include the tumor location, which is limbal, orbital extension, where we see the classification to be belonging to the T3C of an orbital extension and its growth patterns. So as pathologists, these are the pathologic features that represent the tissue effects of your radiotherapy and features related to tumor progression and growth. Insensitivity of the tumor after radiotherapy increases the risk of metastases. So these pathologic features may be helpful prognostic indicators for patients with conjunctival melanoma. So these are the questions we would like the panelists, if we can show this for discussion. Is it still possible to perform your proton beam radiotherapy or plaque brachytherapy after EBRT failure? Does the tumor size, its thickness more than 2 millimeter, and its location prevent effective complete treatment? And is there a role of your targeted therapy, like BRAF inhibitors and immunotherapy in a conjunctival melanoma that is not responsive to radiotherapy? Thank you.
Thank you, Dr. Sua. Professor Sa?
Yeah, I'd like to share my slide for more efficient discussion. Can you see my slide?
Oh, it's coming up.
Okay. So I'd like to thank Dr. Sua for sharing this informative and very informative cases showing lots of clinical behavior of conjunctival melanoma including it's very recurrent, locally invasive, and radio-resistant. And key histological insight also include the residual viable melanoma despite radiation treatment. Considering this patient is relatively young women, so we have to consider both quality of life, function, and organ preservation, as well as long-term survival. So probably the previous surgery, previous radiation treatment as an initial treatment has a rationale for the organ preservation. However, considering her younger age, we need to consider more about long-term survival. So I believe the accentuation was an unavoidable decision. For treatment of conjunctival melanoma, the mainstay is a wide local resection with cryotherapy, and topical chemotherapy is very useful adjuvant treatment. But despite of this kind of standard treatment, there remains still high risk of recurrence and metastasis. And radiotherapy is not a first-line treatment usually. It's usually used as a adjuvant or salvage treatment for cases of positive margin when resection impossible or patients unfit for surgery. So this particular patient showed many evidences of advanced disease. So orbital accentuation is quite indicated. So other indication could include the diffuse orbital invasion, especially extraocular muscle involvement, just like in this case, and orbital involvement following multiple recurrences. So I believe the adjuvant radiotherapy could be helpful rather than neoadjuvant or initial radiation treatment, especially when the surgical specimen shows a positive surgical margin or perineural or vascular invasion. So I think eye-sparing approach could be indicated only in highly selective cases, such as the limited anterior orbital extension within the context with intensive multimodal therapy. So I'd like to emphasize the importance of the immune checkpoint inhibitors, including anti-PD-1 or anti-CTLA-4 inhibitors. It can be indicated for unresectable orbital extension or recurrent or metastatic diseases, showing a good evidence these days. And as Dr. Soa mentioned, the BRAF plus MEK inhibitor could be indicated, but only if the mutation is presented. But as you all know, the conjunctival melanoma is not strongly associated with the BRAF mutation, so it is more useful in case of cutaneous melanoma. Our group also reported the immune checkpoint inhibitors and usefulness of conjunctival melanoma, especially in an attempt to avoid orbital accentuation. So I believe in case of conjunctival melanoma with the orbital extension, we should consider accentuation plus minus adjuvant radiation treatment or immunotherapy, or immunotherapy could be considered as a first-line treatment and surgery if needed. So the conjunctival melanoma require aggressive treatment, including wide local resection, cryotherapy, and topical chemotherapy. And the recurrent or locally advanced melanoma is a very high-risk malignancy, and multidisciplinary treatment is required, especially immunotherapy is promising. Yeah.
Thank you.
Thank you.
Professor, I'd like to invite Professor Copeland to give her expert comments. She's
Thank you very much.
Expert. Yeah.
I just like to ask one question. When the patient first presented, did I understand correctly that no histology was undertaken at that stage?
That's right, Dr. Copeland. So in our place, sometimes we as pathologists, we don't really receive this specimen. And of course, in cases that there are no pathologists at all.
Okay, so she was treated as if it was melanoma without the biopsy. Okay, so just one.
Was initially treated as a case probably of a nevus and was removed because of this very small lesion and was not submitted for histopathologic exam.
Okay, so just just to perhaps correct something that was just given in the presentation, the BRAF mutation occurs in about 45% of conjunctival melanomas, so it's not rare. What happens whenever we diagnose invasive melanoma of the conjunctiva, even if it's microinvasive, we perform the BRAF mutational analysis so that it's right at the very beginning of the patient's treatment that is documented should the patient develop metastasis. And to do the BRAF testing, it's really quite simple. It can be a targeted test and can be performed from DNA extracted from formalin-fixed paraffin-embedded material. So I strongly recommend that the BRAF testing is performed, and usually if there's no BRAF mutation, then there's either an NRAS or an NF1 or even a TERT mutation. They're the four main mutations. But what was demonstrated there also in the slides, the very good response usually of conj melanomas, similar to skin melanomas, to immunotherapy, possibly in addition to the targeted BRAF inhibitors. So it's worth considering that. And just last but not least, very nice histological pictures, and just another marker which I probably would suggest to highlight more easily the viable tumor cells would be using a red chromogen and possibly SOX10 rather than the HMB45.
Thank you so much.
Yeah, there was no information about the systemic evaluation in this patient, but I assume for now there is no evidence of systemic metastasis. But based on the high malignant behavior of the disease, so I think there is a good chance of for patients to have some systemic metastasis in the future. So I also recommend to perform the gene mutation check first, and then immunotherapy could be helpful to prevent the systemic metastasis or disease-related deaths, I believe.
Yeah, and it could be, it could be that the oncologists ask for the PD-1 and PD-L1 expression levels in advance of the immunotherapy.
Great. One quick question for Dr. Copeland. Does the tumor thickness and its location also make it more difficult for the radiotherapy? Do we still consider the Breslow thickness in terms of metastasis?
So with conjunctival melanomas, we can't apply the Breslow score because that's applied to skin melanomas only. So we describe the depth of infiltration, what the tumor cells invade, and yes, use the TNM staging system in terms of whether there's intraocular involvement, whether there's orbital involvement, and so it's at least a PT3, if not a PT4, this tumor.
Right. Thank you.
Great case. Thank you very much, Professor Sua, Professor Aksa, and Professor Copeland. Let's switch over to Dr. Veerwan's presentation from Thailand, whose interesting case is going to be discussed by David Honglei Lu, a good friend and Vice President of AP Sopras from Xi'an, China. So, Veerwan, we can't hear you, but we can see your slide.
Dr. Veerwan, you're on mute. Yes, perfect.
All right. Good afternoon, everyone. Good afternoon from Thailand. And this is my honor to be a part in this webinar to present an interesting case with of you guys. So should we get started? This is a 70 years old male with a long-standing history of hyperpigmented lesions at lower eyelid since he was young. But in these last 2 years, the lesion get increasing in size and also get darkening of the color. Like we see here, the involvement of the lesion is that left lower eyelid margin, and also palpable conjunctiva, and also lateral canthus. He has good vision, no orbital sign, and no palpable of lymphadenopathy. Yes, a long-standing hyperpigmented lesion with behavioral change. We should concern for the malignant melanoma. And right now, the tissue diagnosis is needed, right? So we should go for excisional biopsy or incisional biopsy. And about the tumor seeding, do we need to be concerned? Yes, by theory, we need to concern for the incisional biopsy for the hyperpigmented lesions. But for the current evidence, that is not any support the significant risk of this concern, and also the location and extent of the lesions. So we designed to go ahead with the incisional biopsy for the full thickness eyelid, get involved eyelid skin, eyelid margin, and also the conjunctiva. Histopathology compatible with the malignant melanoma in situ. For the systemic workup, is clear. And we can see the molecular study, this show positive for BRAF mutation. Do we need to go ahead with the sentinel lymph node biopsy? For regional metastasis and distant metastasis, this need invasive picture. But for this patient, he has malignant melanoma in situ, so that we didn't see any pictures of the invasion into the stroma or dermal. So we doesn't go ahead with the sentinel node biopsy. But for the systemic workup, we do prefer to have a baseline reference for the multidisciplinary decision-making for the treatment plan. Exactly, this is a tumor that can resectable, but after the resection with the clear or margin, the patient's going to have quite significant morbidity after the surgery. So the question of us is, can the anatomy preservation approach possible? Yes, it's possible because we can identify the targetable mutation of the lesions. So now our goal, we would like to preserve the organ, and we would like to have an oncological safety too. After the tumor board discussions, we designed to postpone the surgery, and we would like to start the BRAF inhibitor plus with MEK inhibitor. We would like to downsize the tumor. We would like to preserve the anatomy and organ, and the surgery still remain an option and available if the lesion was progressed. And this is the result of the treatment. After 10 months of the treatment, we can see dramatic regression of the pigmentation. But if you see the extent of the lesion, the reduction of the extent of the lesion was not that much. At this point, if we would like to go ahead with the surgical excision, the patient still get quite significant morbidity after excision. But anyway, right now, the patient still keep using the medication with still ongoing of the regression of the lesions without any toxicity of the medications. So now we plan to keep using the targeted therapy until no more change or no more regression of the lesions. But anyway, we still have the question. When the lesion is not further regression, can we just stop the treatment, or do we need any kind of biopsy? And how can we do with the biopsy? And if the biopsy came with negative result, can we just leave the lesion like that, or do we still need more excision? And after we stop the medication, any rapid growth after we stop the medication? This is the point for discussion. Thank you.
Thank you, Professor Veeravan. Very interesting and challenging case, dramatic result. David from Xi'an, could you comment? And also maybe a little comment about the availability of various immunotherapies and targeted therapies in China where you practice.
Okay, I think it's a wonderful presentation of several cases of conjunctival melanoma. So I'll share my PPT first.
But are we even convinced this is pure conjunctival melanoma versus eyelid?
Dr. David, would you like me to share or would you like to share the screen?
I share my screen.
Okay.
Could you help me? I have sent you to
Yeah, I'm just sharing the screen. Just a second.
Okay.
Yeah, it's ready. Let me know when you can see the screen. Is that okay?
Maybe I use my cell phone. Okay, so
go ahead, David. She will advance the slides for you.
Yes. So I think I'll share some opinion about conjunctival melanoma. The topics stepwise treatment strategy. Yeah, next. So I think what we should focus is the first is the stratification basis. First is the tumor depth assessment, vision scope analysis, and metastatic status evaluations. So we have three treatment progression. First is the local control, and second one is the regional management. Third is the systematic therapy. So the first stage we call just as the doctor shows, it's a in situ localized disease. So what we usually do is the total resection of the abnormal. Usually at the beginning of my career, I usually resect more than 7 to 8 milliliter, but some guidelines showed only 2 or 3 the normal surrounding tissues. They will stop, but my experience, I usually do 6, so maximum is 8 millimeter safety margin for the resection. Then we use the local eye drops with interferon eye drops for the routine treatment for the patient. So next slide. So the stage 2 is the locally advanced disease. So we will choose the new adjuvant immunotherapy. The first is the nivolumab with the relatlimab combination. It's a evidence-based approach. Since 224 JAMA ophthalmology, we see the very strongly support document for the treatment. Next slide. So the stage 3 is the local advanced regional metastasis. For this period, we usually choose the dual checkpoint inhibition for the first line. Choose the first is the ipilimumab with the nivolumab. The second one is nivolumab with the relatlimab. So I think the both is our choice for the stage 3 for the treatment of the this stage patient. Next slide. So for the distant metastatic disease, it's now easy to deal with just because patient usually have the bone pain and some damage to the liver or the kidney. So what we choose is the dual immunotherapy, maximize immune activation for the dual survival benefit. And for the salvage therapy, we choose the clinical trial enrollment. We give the Genopain direct therapy, such as breath detection, and we usually choose the local radiotherapy for the symptomatic lesions to improve the quality of the life. So next slide. So for the summary, well, first, if the only a localized ocular surface, we just do the surgery and typical therapy. What we routinely use the interferon eye drops for the patient. So it's usually work well. More than, I think, in our clinic center, more than 90% of patients, the pigment disorder has gone with the eye drops with the interferon. The second one is a local advanced, but without any metastatic. We use the primary surgery. We use the adjuvant immune therapy for it. For the regional lymph node metastasis, we will choose the dual immunotherapy with the lymphoanedotomy and to control the lymph node metastasis. For the distant metastasis, it's really sometimes it's at the end of the patient life. So we try our best to save the lives. We do the systematic immune therapy and with the local radiotherapy for the improve the quality life of the patient. So next slide. So
this is the last.
This is the key reference I have reviewed for the subsequent patient. It's usually most recent review of the conjunctival melanoma. Thank you very much.
Thank you, David. Great discussion. Could I invite Didi or Krishna to make some clinical comments and surgical comments, including specifically when you do a full thickness incision biopsy, we're obviously not adhering to the no-touch technique of a total complete excision. Your experience on that, and maybe Professor Copeland also, or Derek, comment upon, is this really an eyelid versus conjunctival melanoma? Because there's both components to it, and how does it change management?
I'll just have a brief comment here, Ganga. Thank you. Great case. They've all been great cases. I think, to me, this looks like a cutaneous melanoma with conjunctival extension. Though the biopsy shows it to be melanoma in situ, given the extent of the disease, almost certainly you'll find there will be an invasive melanoma component in that disease. And that's always the limiting factor when you take an incisional biopsy, whether it's full thickness or you've taken at best 5% of the tumor surface area as a biopsy. I think probably all of us would have treated this as a invasive melanoma, and how you go about treating it. I think if you've got access to sentinel node biopsy, I think we'd probably do sentinel node biopsy on this, and I would have performed surgery as the first line treatment for this, and then reserved immune checkpoint inhibitors, depending on what the outcomes of histology and long-term survival are.
Or even at this stage, when you achieved a significant reduction, there's residual lesion, would you attempt a surgical excision adhering to surgical principles rather than just wait and watch as a long-term management? So anyway, great. So yeah, we're running out of time. So we'll move on to the last case. Thank you, Professor Veeravan. Great case, challenging case. Probably we should have a post-meeting discussion on these cases. Let me invite Dr. Megha from LV Prasad Eye Institute to share an interesting case, which will be discussed by Professor Krishna once again. Megha?
I'm sorry, I'm from Center for Sight, Hyderabad, India.
Oh, sorry, Center for Sight, Hyderabad. Sorry.
Yeah. I'll just share my screen.
I'm getting all names and addresses wrong.
Is my screen visible?
Perfect.
Just a second. Yeah.
Lacrimal glands are always fun.
1 second.
Yeah.
This one, just a second. Yeah. Is my slide visible? Okay. These four seemingly ordinary clinical pictures give no hint of the artist's journey behind them. Namaste from Center for Sight, Hyderabad, India. Today we unfold the lessons from a relapse in managing adenoid cystic carcinoma of the lacrimal gland. This 33-year-old young female presented to us with severe pain in her right eye of 1 year duration, who underwent orbitotomy with incisional biopsy via a lid crease incisional approach in Canada. She was confirmed as a case of adenoid cystic carcinoma of the lacrimal gland and referred to us for further management. Her MRI indicated a well-defined mass lesion in the right lacrimal gland, with displacement and compression of SRLPS complex and the globe inferomedially, with suspicious periosteal invasion till the apex, confirmed on coronal sections with perineural invasion of ophthalmic division of trigeminal nerve. A PET-CT ruled out metastatic disease. At this point, multimodal management protocol was initiated. She was treated with 3 cycles of neoadjuvant intravenous chemotherapy with a combination of paclitaxel and cisplatin at 3 weekly intervals, with a goal to make it amenable for surgical excision. But the tumor had other plans. The patient's repeat imaging showed an increase in tumor size and infiltration of LR, LPS, SR, and lateral canthus, while the perineural and periosteal invasion showed no resolution. Such unexpected response to chemotherapy implied chemoresistance or possibility of a pathological variant. We went ahead with surgery. After tagging the superior and lateral recti, a modified stellarite incision was made from eyebrow cilia till the zygomatic arch. Subcutaneous dissection was done to reach the periosteum via a transseptal incision. Periosteal incision was made, followed by gentle dissection of the periosteum from the orbital wall using a periosteal elevator. A transseptal en-bloc excision of the tumor, ensuring complete dissection with the invested periosteum intact, was performed after ensuring it is free of all adhesions and ballotable, making it amenable for cryo-assisted delivery, as you can see. Once the posterior pedicle was detached and hemostasis was achieved and closure was done in 2 layers of orbicularis and skin. As intended, we were able to excise the tumor to the maximum extent possible with the investing periosteum intact. Histopathology revealed adenoid cystic carcinoma of lacrimal gland with neural invasion, with IHC positive for CD117 but negative for HER2/neu. A next generation sequencing showed Notch1 positive. The patient was taken up for extended field adjuvant external beam radiation therapy with a clinical target volume as appropriate with a radiosensitizer cisplatin. We had progressed to the penultimate phase of a multimodal protocol. She opted to continue care locally. However, her treating team considered therapy complete and adjuvant intravenous chemotherapy was not administered. The patient could not come for her 6-monthly follow-up but kept us updated with her MRI and PET-CT, which was suggestive of post-operative changes. But her repeat imaging at 1 year was suggestive of a recurrence. There was a clear increase in size of a soft tissue lesion extending right up till the apex, involving the LPS SR superior oblique with thinning of roof and perineural invasion of ophthalmic division of trigeminal nerve. An en-bloc excision biopsy of the recurrence was performed via anterior orbitotomy due to the location of the tumor being along the superior orbital wall, along the LPS-SR complex, followed by placement of silicon conduits in preparation for afterloaded brachytherapy. The tubes are placed along the superior orbit equidistant from each other till resistance was felt at the posterior most point. It was snugly fit, anchored to the orbicularis and skin, and secured with retention devices. Tissue diagnosis again confirmed adenocystic carcinoma of the lacrimal gland with perineural invasion. After meticulous planning and mapping of the target area to involve the affected area adequately, single planar interstitial brachytherapy was delivered in a dose of 30 gray over 2.5 days. Over the postoperative bed through 5 flexible tubes. The patient did well with post-op doses as expected, which was planned for repair later. This slide summarizes the case so far, following which she also received adjuvant IVC 6 cycles with second-line chemotherapy drugs, cyclophosphamide, doxorubicin, cisplatin, in view of poor response to the neoadjuvant chemotherapy drugs. At 6 months of follow-up, her visual acuity continues to remain 6/6 with residual ptosis, which is planned for correction after a year. She's planned for repeat imaging 6 monthly for 3 years, followed by annually for 5 years. This seemingly normal face harbored a life-threatening malignancy, but the scar or ptosis here represents survival. This case is a humble reminder that vigilance outlasts victory. The disease returned silently, and so did the patient, simply because of a message from a training fellow's phone. Sometimes survival is not written just in protocols, but in persistence of the entire team. Thank you.
Thank you, Megha. Over to you, Krishna, for your expert comments.
Mega fantastic case. To be honest, adenoid cystic carcinoma management is probably the forefront is in Hyderabad with Professor Honova, to be honest. Orbital brachytherapy treatment is not something that we have any exposure to, nor do we see the sort of number of cases that he and Swathi and other oncologists in India would see. So multimodal treatment is slowly becoming the standard of care, but it's very difficult. And probably the patient went back to the West where they're not familiar. Oncologists are not familiar with sort of aggressive treatment of adenoid cystic carcinoma. We do know that adenoid cystic carcinoma has a high rates of recurrence. In my youth, when I've done a few cases, you think you've won, but you live long enough, unfortunately, it does tend to recur. And certainly the paper that Dr. Farouz and Dr. Honova published in, I think it was 2019 might be, or 2020, with multimodal showed significant improvement in terms of reduced rates of recurrence and reduced rates of systemic metastasis as well. So I think certainly this case highlights how you manage a very challenging case. Again, I guess you can't pat yourself on the back just yet because the nature of this disease is it may well come back, but certainly you've thrown everything at it, including the kitchen sink. So amazing, great case.
Thank you, sir.
Thank you, Krishna. Maybe invite Derek or Professor Sarah again. You brought up the wonderful issue of revisiting the diagnosis when it doesn't quite behave the way you expect it to behave with neoadjuvant chemotherapy. I don't know if Professor Coupland is still here or not, or Derek. Again, the issue of adenocarcinoma versus adenoid cystic carcinoma versus ductal carcinoma, mucoepidermoid carcinomas. How often are we making misdiagnosis? This year? Or David?
Can I give a short comment? Yes, I think it's a very interesting case. From the first images of MRI, we show it's a very typical images of ACC just because it's with a great enhancement and with a long tail leading to the apex. I think it's from our appearance, we usually give a diagnosis before the surgery as a ACC. So we'll do the same incision, do surgery with the crystal. Without no touch technician, it's very good. But I think this case, we should go more deeper to give some burning on the surface of the periosteum with the bovi, just because we can see some of the enhancement of the periosteum leading to the apex. So I think we should go much more deeper after you remove the majority of the, even it seemed to be intact tumor, you have been removed, but we should go deeper to burn the end of the nerve and the periosteum. That's my appearance. But I think she did very perfect work. Very good appearance. Thank you.
Thank you. Thank you. In the interest of time, we're going to
sorry, just for me, there's nothing
Oh,
much
Derek,
to
yeah,
add.
yeah.
There's
Yes,
nothing
go ahead.
much to add about pathology because it's for this case, it's very textbook-like. There could be formed solid tubular areas, as well as the immunostaining, and we even have a Notch1 mutation that shows that it's going to perform worse than other ACCs.
Yeah, great. Thank you. There are any other comments? If not, thank you very much, presenters, and thank you very much, panelists. It's my pleasure to hand over to the brain behind this entire webinar, Dr. D.D. Fabian.
Thank you, Ganga. So, having a post-webinar meeting is not such a bad idea. Okay, to all the brave ones who are still with us, we surrounded the eyeball from all directions and now going inside. So the first presentation will be given by Leanne Lim from Australia and will be discussed by Vikas Ketan, who I'm not sure I saw online, but we'll start. Please, Leanne. Thanks. You're on mute.
Can you see the slides?
Yes, but not on presentation mode.
Oh, hold on a minute. Here we go. Thanks for having me. So this is a case from Sydney, Australia, and it's a case of a 60-year-old gentleman and demonstrates kind of management of cutaneous melanoma in the era of targeted and immunotherapy. So his background is that he was diagnosed with cutaneous melanoma back in 2011 with a right chest wall lesion and was treated with surgery and requiring a lymph node dissection. And then he had adjuvant systemic immunotherapy on a trial for 6 months. He then recurred in 2017 with a recurrence in his right neck, which again required surgery. And then he was treated with adjuvant MEK and BRAF inhibitors, which had to be discontinued as he developed posterior reversible encephalopathy syndrome. 2 years later, he presented to a uveitis colleague of mine with right eye idiopathic uveitis, which was hypertensive to a pressure of 44 with iris bombay. He was treated with topical steroids, glaucoma medications, and Ozurdex. And he wasn't on any immunotherapy or targeted therapy at the time. He then developed a cataract, which was treated successfully, and then later on presented with iris neovascularization, which was treated with intravitreal Avastin, and then finally recurred to myself a few months later as the neovascularization wasn't responding to the anti-VEGF. And on gonioscopy, the uveitis specialist noticed a ciliary body mass. A systemic screen was done, which showed no evidence of disease on PET-CT or on MRI. They couldn't see any ciliary body mass. So this is what the lesion looked like. He had good vision and well-controlled glaucoma, but the pupil was unreactive to light and there was no reverse RAPD. He had florid 360 degrees of neovascularization in an otherwise white eye. There were some KP in the inferior half of the cornea and some anterior chamber cells. His PIs were patent, but on gonioscopy, the angle was closed with this 3 o'clock iris elevation. And on transillumination, this lesion was amelanotic, vascular, and transmitted light. On UBM at 3 o'clock, the ciliary body was thickened to a measurement of 3 millimeters with cysts present. So to summarize, he has good vision, glaucoma, anterior uveitis, and neovascularization, which wasn't responding to Avastin, a ciliary body mass, which was cystic to 3 millimeters on a background of his previously stable metastatic cutaneous melanoma. So the options for management included observation, anterior chamber tap, and ciliary body biopsy. So the uveitis specialist did an AC tap, but unfortunately they didn't get a diagnosis. And then he was referred to another colleague who did do a scleral cut down and an FNA. But again, unfortunately, this was non-diagnostic. So 9 months later, the vision had slightly decreased to 6/15. His glaucoma was getting worse, now requiring maximal medical therapy and Diamox. And he developed these fluffy white precipitates on the endothelium and on the lens and in the angle. Unfortunately, the ciliary body mass also showed signs of growth and now could be seen on MRI and also PET-CT. So we performed a transscleral biopsy and with a plot. So you can see that it is kind of transmitting light on the TI. And then we reopened the scleral trapdoor and the lesion was very grey and gelatinous. It was difficult to grasp and we took as much as we could and then placed the plaque. So the pathology did confirm that the ciliary body swelling was consistent with cutaneous melanoma and BRAF V600E mutant, and this was consistent with his previous surgical resection. So it was confirmed cutaneous melanoma metastatic to the ciliary body. So, and so 9 months post radiation, he had a nice response and it decreased down to 1.36 millimeters. And he also had full resolution of his neovascularization, his anterior uveitis, and his glaucoma all settled as well. So he lived happily ever after. But unfortunately, he then developed an idiopathic retroperitoneal fibrosis, and he had acute ureteric obstruction requiring stents, and he had to be placed on a weaning course of oral prednisone. And then he presented back to me and said, "Oh, doctor, I noticed this in my eye." And on MRI, we could see that it was T2 hyperintense, a preseptal mass, and was FDG avid. So he actually went to see Krishna Tumaluri, and he did an incisional biopsy, which again confirmed cutaneous melanoma metastatic. So 4 months later, this is his response. And so what treatment did he have? Was it surgery, radiation, or medical therapy? And so after our MDT meeting, he was treated with targeted therapy and had a complete response. So this is a rare case of cutaneous melanoma metastatic to the ciliary body. It is rare. It usually goes to the choroid or presents with vitreous disease. But our discussion was, is the incidence increasing because more and more of these patients are on immune checkpoint inhibitors, or is it because they're surviving longer? So thank you very much.
Thank you, Leanne. Is Vikas with us? Probably not. So these are rare cases, and they usually present in a bizarre way. It's not like a uveal melanoma, a choroidal or ciliary body melanoma. I wonder, after you made the kind of definite diagnosis after the biopsy and you decided to treat with a plaque, would you, in retrospect, treat, and I mean, understand that it's a metastatic cutaneous melanoma and not a primary intraocular tumor. So in retrospect, would you treat with BRAF or MEK inhibitor, like systemic disease?
Yeah, so this was discussed, and I think that the medical oncologists were hesitant because he had
Perhaps as neoadjuvant.
the press. Oh, yeah. So they were very hesitant, actually, even to give it to him when he had his recurrence, because he previously had the press with the reverse encephalopathy. And so that was the reason because he had no other disease, it was an oligometastasis, that they recommended that we treated locally first. And yeah, it was really at a push that they actually gave him the systemic therapy even for the orbital disease, because and I think they had to cover with steroids. They were just worried that he would get other side effects. And I don't know if other people have had experience with the use of systemic therapy as well. In general, they do have quite a lot of side effects, and they can really knock the patients around. So I think more and more our medical oncology colleagues, do use it, but are aware that it can really have other serious side effects for the patients.
Yeah. Challenging case, well managed. Sarah?
Hi, thank you very much. A really very interesting case. I don't think I've seen a metastasis of skin melanoma to the ciliary body. Typically, as you say, it actually occurs more often in the vitreous, the metastases, or to the retina. It actually rarely metastasizes to the choroid, which is an odd thing.
Yeah.
Probably what we would have done in this case is not only have done the testing for the BRAF, but also would have done the testing for GNAQ, GNA11, just to rule out it being a primary uveal melanoma.
Mm-hmm.
And then I just have a question regarding, two questions, sorry. The recurrence that occurred in the conjunctiva/sclera, was that in the region of where any of the surgery was undertaken? Could that have been a result of seeding?
Yeah, so the biopsy was at 3:00, and the recurrence was infratemporal. But I do think that because he'd had the previous trapdoor biopsy without any plaque brachytherapy, so that was just done on its own. And when we went back in, I think that it was, there possibly was some communication at that time.
Right.
So,
and sorry, I know Martina wants to ask a question, but very quickly, is there any evidence of CNS disease? Because often when you have metastases to the eye of whatever type, breast carcinoma, lung carcinoma, it's not long before the patient unfortunately then develops CNS mets in addition.
Yeah, so he hasn't had any CNS mets, but actually, furthermore to this case, he did actually develop more recurrences further around the ciliary body, and so we did end up enucleating him. but to my knowledge, he has no recurrent disease systemically to date.
Thank you. Martina?
Yeah, we did have a case a few years ago of a patient who had metastasis to the ciliary body, and we did give a proton beam radiotherapy, but he, unfortunately, as Sarah mentioned, died of metastatic disease in the brain shortly after. So I think it's a very aggressive disease in this kind of patients. So ideally, the eye have to try symptomatically. I think being more aggressive with proper radiotherapy, unfortunately, does not stop the rest of the disease. So in retrospect, I do not think I would have given proton beam again to a metastatic cutaneous melanoma, and ours was proven with, I've never seen anything growing so quickly. Then we suspected it could have been a MET. I thought it was a dual primary, but by the time we discussed with the oncologist and we were do match biopsies to compare because he already had his primary, the lesion progressed and spread in a way that it was clear a metastasis, and it did respond to proton beam, but then the brain followed so shortly after that in retrospect, I think it's not worth radiotherapy this patient locally.
Yeah, it could be a very aggressive disease, but nowadays 30 to 50% of stage 4 metastatic cutaneous melanoma reach cure, with immunotherapy. So times changed. And even diagnostically in our field, in the era of liquid biopsy, so perhaps in the coming years, an ACTAP will be more informative. Less invasive and more informative. Okay, so thank you for this interesting discussion. We'll move on. The next presentation will be given by Xiaolo Yang from China and discussed by Dona Trojanoporn from Thailand. Thanks.
Thank you, Dr. Fabian, and it's good to have me here on the webinar. It's my great honor to have the opportunity to present the case here. Can you see my slide?
Yes, not in presentation mode, but we can see, now we can.
Okay, thank you. So this is a 56-year-old female with no prior medical history, presented with a 2-day history of photopsia and reduced visual acuity in the left eye. Her fundus examination showed a diffuse yellow-colored choroidal mass with an irregular surface nasal to the optic disc, accompanied by inferior subretinal exudative subretinal detachment. So B-scan ultrasound showed a choroidal lesion exhibiting acoustic hollowness, and the OCT across the lesion showed an undulating surface of the lesion and subretinal fluid. So the fluorescein angiography and ICGA showed no distinct features of the tumor, including double circulation or hyperfluorescence. And orbit MRI showed hyper-intense on T1 weighted and hypo-intense on T2 weighted with contrast enhancement, suspicious of choroidal melanoma. So we did a systemic evaluation, including PET-CT and hematologic screening, which showed no abnormality except for the increased FDG uptake in the left lobe, suspicious of a malignant tumor. And during the 2 weeks of evaluation, systemic evaluation, the lesion demonstrate rapid enlargement accompanied by increased subretinal fluid, and vision deteriorated from 20/60 to 2200. And it can better show on the ultrasound with thicker in the thickness, and also a potential to extraocular extension. So the diagnosis was still inclusive, but given concern for malignancy, we still did a fine needle biopsy, fine needle aspiration biopsy accompanied with iodine-125 plaque radiotherapy. Unfortunately, the cytopathology analysis was inclusive, but the patient responded well to the treatment. This was 1 month after the surgery. We can see that the lesion significantly shrink with reduced subretinal fluid. This was shown on the ultrasound. And 4 months after the surgery, the lesion on the nasal part seems to be completely flat with small amount of subretinal fluid. And 8 months after the surgery, the lesion, we cannot see any sign of the lesion on ultrasound on the funduscopic photo, and no subretinal fluid at the fovea. And the patient had her vision improved to 20/50. So this was a middle-aged female presenting with painless and unilateral vision loss and no prior history of systemic disease. There was a diffuse choroidal mass with exudative retinal detachment in the left eye, showing rapid disease progression, but it was highly sensitive to local plaque radiotherapy. So we're still suspicious of this lesion to be a choroidal lymphoma, and we asked the patient to have a close follow-up and a regular systemic evaluation. However, 1 year later, the patient reported new onset tailbone pain. Imaging identified a retroperitoneal mass, and a biopsy confirmed a diagnosis of myeloid sarcoma. Patient underwent systemic chemotherapy followed by bone marrow transplantation. So myeloid sarcoma is a rare extraordinary tumor most commonly associated with acute myeloid leukemia. This malignancy can present in the absence of peripheral blood abnormalities. And intraocular invasion with MS is exceedingly rare and has previously reported only in the context of systemic disease or leukemic relapse. So this is a case that showing a choroidal lesion that suspiciously like choroidal lymphoma, but it turned out to be a choroidal sarcoma. So multidisciplinary collaboration and close follow-up is very important for such kind of patient. Thank you.
Thank you. It's a very great case, and you nicely managed. Congratulations. I would like to highlight a few important points that I learned from this case. Is that hematologic malignancies, although it's rare, but it should be on the list of choroidal involvement in the eye. And you can see from this case that sometimes ocular features, ocular manifestations can precede systemic manifestations. So we have to keep monitoring these patients. And in your case, from the imaging, even though cytology is inconclusive, but from imaging, multimodal imaging, EDI, OCT, ultrasonography, it shows that this tumor is quite infiltrative and it's not solid. So maybe suggestive of lymphoid tumors or hematologic tumors. And I would like to ask that if have you performed the fundus autofluorescence? It may show some suggestive of the differential diagnosis. It may help us to diagnose further. And also in this case, you see that the mass grows very rapidly, which is not common for melanoma. And choroidal metastasis may grow, but not at this fast. And for the treatment, I would like to ask why you choose plaque radiotherapy over external beam radiotherapy or proton beam, because it looks quite extensive. And you said you're using the iodine plaque, and what was the size and what was the dosage?
Thank you for your question. Very professional and good questions. First, we did autofluorescence because we routinely doing autofluorescence during the fluorescein angiography, but I didn't show the pictures on the slides. There was no hyperfluorescence on the autofluorescence on the picture, indicating maybe there was orange pigment, suspicious of choroidal melanoma. So overall, the fluorescein angiography show no distinct features that could help us to make the diagnosis. And regarding the plaque radiotherapy, yes, I agree that the lesion is quite extensive, but because it's primarily located nasal to the optic disc, the nasal part, so I still think plaque radiotherapy can cover the whole lesion, and plaque radiotherapy with a local radiotherapy, the side effect will be lower. So it turned out to be that the plaque is can completely cover the lesion and give good treatment response. And the total lesion, because I suspect this was choroidal lymphoma, and usually we won't do a very high radio dosage to a choroidal lymphoma. So I choose 40 gray to the topic of the top of the tumor.
So you use notch plaque. You use notch plaque.
Notch plaque, yeah.
Notch plaque. Okay. Thank you. Great case. Great.
The fine needle aspiration biopsy was inconclusive. What kind of needle did you use? And did you consider using a vitrectome for that?
Yes, I was using a 20 maybe 27 gauge a needle that was usually I used to do a biopsy of the melanoma, but since the tumor, when I do the biopsy, I think the tumor is a little bit not that solid, so it looks like I cannot get enough cells from the tumor.
Yeah. Sarah?
Yeah, just a comment. I think you can't say definitively that this was a choroidal manifestation of myeloid sarcoma, just because you didn't make a definitive diagnosis, which was a wee bit unfortunate. But I guess my question is, once the myeloid sarcoma was diagnosed in the retroperitoneum, was the bone marrow investigation undertaken at that stage to confirm an AML?
Yes.
Okay, it was. Okay, right. And I did have another question, but it's gone out of my head. Sorry. Anyway, it's oh yes, just a comment also that we all know that you can have a primary tumor elsewhere, and you can have paraneoplastic syndromes occurring with visual manifestations. So, for example, you can get the B dump occurring as a result of an underlying systemic malignancy. And so I guess it can't be ruled out that this could be some paraneoplastic manifestation in the eye of the AML. Anyway, very, very interesting case.
Thank you.
Challenging case. Thanks for this. We'll move on. Next presentation will be given by Peter Hayden from New Zealand and discussed by Martina Anghi from Italy.
Oh, thank you. Can you hear me? My slides are there.
What's the time in New Zealand now?
Well, it's almost midnight, so I was going to say good evening, but I might say good morning from the 15th of February in a couple of minutes. Yes,
thanks for staying with us.
It's getting late. But yeah, no, I'm Peter Hayden. I'm a part-time ocular oncologist in Auckland. Because of our small population, we haven't got enough to support a full-time ocular oncologist and otherwise a vitreoretinal surgeon. So I first met this female in 2009, aged 11, when an optometrist noticed these above findings, and she was asymptomatic. At the time, of course, we didn't have Optos, but you can see there's a red tumor in her left eye with large feeder vessels, and there was a similar tumor unable to be photographed in the periphery of her right eye. So a diagnosis of von Hippel-Lindau disease was made. The ocular lesions were treated with double freeze-thaw cryotherapy, as you can see here. Systemic evaluation uncovered CNS lesions, which were treated, and she's been followed systemically ever since. 6 years later, age 17, all looked well, bar a wee touch of traction supranasally in the right eye. However, although her left eye has remained stable ever since, bar a few small lesions that I've treated with laser, at the age of 20, she developed a traction or retinal detachment supranasally in the right eye, in the same area where she'd had traction before. I walled this off with laser, but the vitreous started to detach, and as it did so, actually it came off this area of retina, reduced the fibrosis, and allowed the traction or detachment to settle again. On the other hand, she very shortly thereafter developed a macular hole, so I did a vitrectomy. And the vision improved to 6/9 after that vitrectomy with repair of the macular hole. At the time of the vitrectomy and 3 years later when I did her cataract, I did cryo a few more areas where there was small hemangioblastoma. I had tried laser a couple of times also, but it didn't always destroy them completely, and new ones seemed to appear right beside the older ones. So I did have a bit of a tendency in her to do a bit more cryotherapy when I had a block on, say, for the vitrectomy. 2 years later, at age 25, she started, though, to develop some pre-retinal fibrosis around the arcades. And at age 27, she started to get a detachment near the fovea. So I did a vitrectomy again and removed those pre-retinal membranes. And this appeared to settle everything down, although I shaved the vitreous space as close as I dared, but there's a little bit of fibrosis right at the edge of the vitreous space. 6 months later, though, more bands developed, and she developed a mid-peripheral tractional retinal detachment. This was her fluorescein angiogram at the time. There appeared to be new vessels supratemporally. At about 9:30, there's an obvious hemangioblastoma, but at 11 o'clock, it's more a fan of neovascularization, I felt. So I took her back to theatre, removed the traction, put on a 360 encircling band, and while removing the traction on around the macula, I must have pulled enough to cause a local macular detachment. That macular detachment settled, but just a few weeks ago, 3 months later, the fibrosis has increased again. And you can also see there's certainly a hemangioblastoma here. Did I make a mistake? I wonder if I put on too much cryotherapy between the ages of 20 and 23. I didn't perhaps anticipate as well as I should have the severe traction and fibrosis in this, vitrectomized eye and with all the lesions I thought treated. I was hoping this year to convince our minister to allow her to have Bazoltavan, or at least pay for it, because at the moment in New Zealand, Bazoltavan is approved for use, but the patient must pay for it or have health insurance to cover it. And this patient has neither the means nor the insurance to get it to herself. Be interested to know what people think its role is. The patient doesn't tend to become pregnant. This eye is still not stable. There's an active hemangioblastoma at 9:30, and the traction keeps coming back. And what are the vessels at 11 o'clock? I think it's neovascularization rather than tumor. So I'd be interested in your comments, please. I'll go back to this segment.
Thank you. Thank you very much. This case, I think, highlights the challenges we face as ocular oncologists in treating what seems like benign disease. So Phoenix-Lindau affects the eye in almost 50% of patients, and among these, 87% of them got peripheral forms and 15% have got peripapillary macular forms. Ideally, the approach is to treat the peripheral one as you initially did with laser. So there is not uniform guidelines in what you do with these patients because each one in a way is different. But the overall consensus is the most important thing is to treat lesion if you can catch them less than 1.5 millimeters and laser them because this gives a good control of a lesion peripherally and less complication. However, when that cheapish failed, as in your case, the lesion started being bigger, vitreoretinal surgery is an option. Cryotherapy is being applied widely. However, as you've shown, multiple cryotherapies have as main complication the development of fibrosis and vitreoretinal attractions. Some centers, like the German group, have got experience with brachytherapy for larger lesions. But overall, the problem is the management of the retinal traction. And so having a combination of VR approach is correct. I agree the number of repeated cryotherapy might have played a part in this fibrotic development. I was wondering whether you ever consider to add VEGF because of the peripheral vascularization you're seeing now, and also if you're using peripheral angiography, if you can have access to that, and it's something which could lead your practice at some point, or is this available? Ultra wide field angiography in a more precocious stage than what we see now, of course.
Yeah, well, I was actually hoping to get her on Bazoltafan. That was my default, but that's now gone. So I am wondering how to control the fibrosis. Maybe I should be giving her anti-VEGFs, and what I do about that new hemangioblastoma, which is in an area of fibrosis, which I don't really want to tickle too much, but I think I have to try and laser it and get rid of it.
Yeah, I think in the melzutifan, which is the IF2A inhibitors, which has been approved by FDA, is not even in Europe prescribable just for the eye, but can be in association when you have CNS involvement or renal involvement, and has been very successful in reducing the size of the tumors and be used also as a neoadjuvant. So basically, you can never stop melzutifan. When you stop it, the tumor grow back, but you can shrink the tumor and then laser it while they're on drug. But as you said, this patient does not have access, no means to do it. I see Amit raising his hand. Do you want to comment on this, Amit?
Just to say, our London experience is rather like yours. We would say laser the small tumours. We tend not to do cryotherapy as a rule. If you've got a large tumour, we'll tend to go to brachytherapy, but normally sandwich treatment with anti-VEGF before and afterwards. I think that tends to work quite well, particularly if you've got fibrosis or the retina is lifted up and you've got tumours stuck into the fibrosis part.
Yes, right at the start, the tumours I felt were too large to treat with laser, which is why I used cryotherapy.
Yeah.
But I think I probably overdid it in my
and we have now had our first success with the belzutifan. It's taken a long time to get it. It's been used in London for a systemic case with eye involvement, and it's the first case where we've actually had positive improvement in the hemangioblastomas in the eye just on that treatment. So I think it's hopefully something there for the future.
I was told by Carol Shields that they've recently had access to it for eye tumours only, and it does shrink them away, but it is not nice to hear that as soon as you stop it, it comes back, because she wants to become pregnant, and it's contraindicated with that.
Yeah. We have some experience with a few patients who are on belzutifan, and it works like magic. But yes, it's out of pocket. So it is a problem, and you cannot stop, as mentioned. Okay, any more comments? Martina, Peter, thank you. Great case and discussion. We'll move on. So the next case will be presented by Prapti Cheda from India and discussed by Nathalie Kassou, my good friend from Institut Curie in Paris.
Good evening, everyone. Thank you for the opportunity before I start the case. But can someone just confirm if they can see my screen and if my slides are visible?
Yeah, that's all good.
Thank you. Thank you. So I've titled this presentation as Eye as a Window to the Body. Eye being the small organ can give you big clues. I am Dr. Prapti Chheda. I'm a Retina Fellow at LV Prasad Eye Institute, Hyderabad. I would like to give the case courtesy to my mentor, Dr. Vishal and Dr. Soumya. So this was a case of a 65-year-old male hailing from Nagpur, Maharashtra, who was doctor by profession and had recurrent episodes of redness associated with ocular pain since last 2 to 3 years and a complete loss of vision in the right eye since past 3 years. There was no significant systemic history present. The patient had visited locally to a hospital where on the fundus photos you can see that there were yellowish white creamy lesions superiorly. The disc, although not very clearly seen, but had well demarcated margins, and there was inferior exudative RD. They had done a fundus fluorescein angiography for the patient at that time. The lesion was actually hypo initially in the early phases and had a stipple hyper and hypoautofluorescence at the later stages with an inferior exudative retinal detachment. The OCT at that visit showed clear vitreous with foveal contour abnormal. The retinal layers were well maintained and there was a lumpy, bumpy elevation of the RP, which you can see over here. There was minimal SRF present and there were a few hyperreflective dots seen subretinal. So based on this and considering the profession, they had suspicion whether it was a uveitic etiology or a neoplastic, and the patient was asked for a battery of investigations from which the quantiferon TB gold test was positive. And to rule out neoplastic, they had sent the patient for a PET CT scan, which showed metabolically active tumors in the right optic lobe, the superior basal segment of the left lung and the lower lobe, and the mediastinal and the bilateral hilar lymph. There was no evidence of metabolically active disease anywhere else in the body. The patient wanted a second opinion, so he had gone to another hospital. So there he was started with the diagnosis of a presumed ocular tuberculosis was made, and he was started on oral antitubercular treatment along with oral and IV corticosteroids. So the patient had come to us roughly 3 to 4 months after all this. So he was started on IV intravenous methylprednisolone 1 gram for 3 days, and then subsequently on oral steroids in a tapering doses for 3 months. When there was no improvement, he was referred to an oncology clinic. At presentation, the patient's vision was hand movements, which was improving to 23/20 with AC reaction of cells +1 grading, but the rest of the anterior segment findings were normal in the right eye. The left eye was not affected. On this visit, on fundus examination, the patient had a yellowish white creamy multilobulated lesion superior to the disc. The disc was hyperemic and could not be visible very clearly because of the inferior exudative RD, which is better appreciated on this fundus photo. The left eye fundus was normal. On B scan, you can see a membranous echo in the vitreous cavity, which was suggestive of an exudative retinal detachment, and there was a echogenic mass seen in the choroid, which was causing choroidal thickening. The base of this tumor was greater than the height. On OCT, there were RP undulations seen. There was some vitritis also seen at this visit, and the SRF had clearly increased compared to the last visit. Based on all this, we had a provisional diagnosis, and seeing the PET CT report, we had a provisional diagnosis of a choroidal mets. So we had referred the patient to our oncologist, and where we had asked them if it was possible to do a lung biopsy for the patient. So considering the inaccessibility of the lesion, the choroidal biopsy could not be done, and we went ahead with the choroidal biopsy, which showed the large cells in the 40x magnification on HNE. They had intracytoplasmic mucin highlighted on Alcian blue. The cells were positive for pancytokeratin and were negative for melanate. So a final diagnosis of choroidal mets was made. At last follow, the patient was later on referred to our oncologist, and he was diagnosed to have a non-small cell lung carcinoma. He underwent series of external beam radiotherapy, immunotherapy, and cryoablation. Currently, he is under maintenance and on immunotherapy and no active lesion as per of last PET-CT. The eye could not be salvaged because of the closed funnel tumor. So my take clinic messages would be that persistent or atypical ocular inflammation should prompt evaluation for a masquerade syndrome. The choroidal mets may be actually the first presenting sign for underlying systemic malignancy, and a multimodal imaging would help in the diagnosis, and histopaths would definitely tell you a clear diagnosis. Thank you.
Thank you, Natalie.
Thank you very much. This is a nice case. The multimodal imaging, since the beginning, is in favor of metastasis. I think you agree with that. The quantiferon is positive. The quantiferon is very specific. So perhaps he had both metastasis and the lung carcinoma and latent TB. Fortunately, it was treated, if I understand well. But what I don't understand is why it's not accessible to do biopsy the lung.
So actually, we had sent for a lymph node biopsy, but the lymph node area they couldn't access, and the patient was not willing for a lung biopsy at that point without any actual diagnosis. So he was not convinced.
Okay. So I have no more comments because I think that the treatment is done and the patients do well.
Okay, thank you, Amit. You're on mute.
Thank you. Very interesting. We've had one case quite similar to this, presented with what was presumed to be a granuloma in the choroid, less diffuse, quite sort of well circumscribed. The uveitis team started on treatment, and it actually shrunk and got better. So they thought that's great. You know, they had TB as well, and then subsequently started growing again. And then when we biopsied it the second time, it turned out to be an amelanotic melanoma. It actually improved on systemic treatment, and whether it was the steroids, it certainly shrunk by about 50–60%.
That sounds like a case report to publish.
Yeah, I'll get around to it sooner or later.
Okay, Sarah?
Just a suggestion. I mean, it's clear that it was metastatic carcinoma on the biopsy, and but you could also, if there's sufficient material, you could do the TTF1 on that material as well. And sorry, one last thing is that if there is also sufficient material, you can also extract the DNA from the sample and do the EGFR mutational testing, because then should that be present, then the patient could be treated with the targeted therapy.
Yeah, with
So this
beneficial outcome.
patient,
Yeah.
So this patient, when he had come to us, because we only have an eye setup, so we had done a pancytokeratitis. Once it was proved that this was a choroidal metastasis, when we referred him to a oncosurgeon second time, they actually took a biopsy from the lung, and that came out to be a TTF1 positive. And he was currently on targeted immunotherapy. They have done the they have done the genetic testing as well.
Okay, thanks. I agree with Natalie's comments. So our first choice would be to take a lung biopsy rather than a choroidal biopsy, but you gave your explanation. Okay, last but not least, so a presentation will be given by Purnima Rajkarnikar Stapit from Nepal and discussed by Bhavna Chawla from AIMS, New Delhi. Thanks.
Good afternoon, everyone. Thank you, Didi and others for this opportunity. Am I audible and my slides visible?
Yeah.
So I'll be talking on the dark side of optic disc, melanocytoma versus melanoma. Case 1, a 34-year-old female presented on 10/4/2023 with the complaints of floaters in her right eye for 2 months associated with headache and ocular pain. In medical history, she was hypertensive and had thyroid disorder on the medication. She gives a past history of gunshot injury to right temporal side of the head and got it surgically removed 10 years back, but no documents available. Visual acuity OU 618 improving to 6.9 OD and 6.6 OS. Anterior segment examination was unremarkable. Pupil was 3 mm, round, regular reacting, and no RPD. So fundus photograph of the right eye shows a dark, large brown to black elevated lesion involving the optic disc and the peripapillary area. The margins appear irregular but relatively well defined, and the surrounding retina shows a pale halo around the disc and appear to course, and the vessels were seen to emerging from the disc and course around the lesion. The background retina otherwise appears normal, and left eye fundus was normal. These scan images showed a well-defined dome-shaped intraocular mass arising from the posterior segment over the optic nerve shadow, protruding into the vitreous cavity, and the lesion appears acoustically solid with moderately high internal reflectivity. Visual field right eye shows demonstrated a right temporal hemianopia with significant generalized depression, and color vision right eye showed demoplates only. Left eye visual field and color vision was normal. MRI done at the time showed an encephalomalacia in the right temporal and frontal lobes, a tiny T2 signal, a low signal intensity in the right optic nerve head, which is isointense in T1 scans, and no other abnormalities in bilateral orbit and optic nerve pathways. Neuro-ophthalmologist consultation showed that visual field defect of the right temporal hemianopia was likely secondary to the prior gunshot injury and unlikely due to the optic disc lesion, and diagnosed as hence right eye optic disc melanocytoma and kept on close observation. In 6 months follow-up, she complains of some decrease in vision since 2 months, and there was a 2-line decrease in vision from 618 to 636, improving to 612 only. Fundus picture, visual field, and MRI appears to be same. And then we diagnosed as it was a melanoma, maybe progressing to melanoma, melanocytoma progressing to melanoma. So the patient was also keen, hence we asked for the VR surgeon who did OD core vitrectomy from optic nerve head FNAC and fluid air exchange plus cryotherapy to the pores was done under local anesthesia. Cytology report showed both FNAC and vitreous sample smears showing aggregates of melanophages and no malignant cells seen. Week 2 post-op vision was stable. Recent follow-up vision was stable, is stable. A fundus picture and the visual field remains stable, and the recent MRI also showed a stable disease. Hence, I'd like to conclude by saying that optic disc melanocytoma is a benign lesion that may present diagnostic difficulty, particularly in patients with complex neurological histories, and long-term monitoring and multidisciplinary approach are essential to ensure accurate diagnosis and optimal visual outcome. The pathogenesis of optic disc melanocytoma is unknown, mostly assumed to be congenital, and malignant transformation estimated to occur in 1 to 2% of patients only. But optic disc melanocytoma can show ischemic necrosis, disc edema, intraretinal edema, SRF, and yellow intraretinal exudation, focal hemorrhages, vitreous seeds, and retinal vein occlusion, as shown in the studies. So with this thing in mind, I'm showing a second case, which we saw about 8 years back, a 36-year-old female with sudden diminution of vision for last 2 weeks, and vision was 636. In the fundus picture, you can see a similar grayish-brown, brownish black lesion on the optic disc, but here the rest of the optic disc was edematous with features of CRVO and the flame-shaped hemorrhages all around. MRI at that time showed a mass, T1 hyperintense mass protruding into the vitreous cavity and the optic nerve. Optic nerve was seen to be enlarged up to the whole of the length up to the optic canal. It was uniformly enlarged. It was referred to Center for Sight for further evaluation. It was diagnosed as optic disc melanocytoma with CRVO, disc edema, and optic neuritis, and underwent 2 cycles of TTT, but the patient lost to follow-up at both the centers. They came to Tilganga again after 1 year with vision of query PL. There was the enlargement of lesion, both height and diameter, with query CRVO and old CRVO. Hence, we did enucleation, and optic nerve was found to be stiff and had a black mass throughout. A separate section of optic nerve was also excised, and histopathology reported optic disc mixed cell melanoma extending to optic nerve resected margin positive, and referred to oncologist for metastatic workup and possible radiation to the orbit. However, she was lost to follow-up again. So I'd like to put some questions for discussion. Since conversion of melanocytoma to melanoma is quite rare, so what would be the follow-up routine for such optic disc melanocytomas? Because a yearly MRI may be impossible in our setting where there is no health insurance. It will be expensive for the patient. And apart from enucleation, anything else can be done for melanoma. It confined to the optic disc. For the management of optic nerve melanoma, I would like to ask the expert panelist, as no definite line of management mentioned in literature because it is so rare. Thank you. These are my references.
Right. So
Thank you,
that was an
Purnima.
excellent presentation, Purnima. And may I go ahead, Didi?
Yeah, sure.
Yeah.
Stage is yours.
So, and very challenging cases that you showed. So one by one, let's pick up a few things in both the cases. So the first case was a case of a melanocytoma. And the concern is that how do we differentiate melanocytoma from melanoma? Because we do know that although rare, but malignant transformation has been reported in melanocytoma, 1 to 2% of cases. And so we really need to be vigilant. And what investigations do we have at our disposal to be, fairly sure that we are dealing with a benign lesion? Okay. So yes, clinically, if there is a profound vision loss or if there is progressive growth that you can see on your fundus examination or on ultrasound, then that is also, suggestive of a malignant transformation. Apart from that, having said that, we do know that, about 10 to 15% of melanocytomas can also show growth. So growth is not the only factor that can suggest malignant transformation. So we need to see other things as well. And out of the investigations that can be done, we could also think of doing a fundus autofluorescence, an FFA, OCT, and OCT angiography, because these are certain investigations that can, tell you certain differences between a melanocytoma and a melanoma, or malignant melanoma. So apart from that, if you are suspecting malignant transformation, when it comes to MRI most of the times you will not be able to differentiate between a melanocytoma and a melanoma. So among the non-invasive investigations, these are the ones that we have. And then whole body PET CT again would be doubtful because it may not pick up the primary. Even if it's a melanoma, it may not be able to pick up an intraocular primary. It's mostly for systemic metastasis, but in some in some instances you can pick up the primary melanoma even on PET CT. So that can be an option. And the other thing is that of course, definite, you can only know if you have the cytopathology or the histopathology. If none of these tests are conclusive, then you may have to resort if there is a strong clinical suspicion of malignancy, which you did. So one question here that would arise is that you did a vitrectomy along with the biopsy, along with the FNAC. So what was the indication for the vitrectomy in this case? Could you have just gone in and, just done the final aspiration?
Because our retina surgeons, it was retina surgeon's decision. They said that just doing FNAC would not be possible to reach the optic disc safely. So that's why vitrectomy. They opted for vitrectomy and sent both the vitreous sample as well as the disc.
Right. Okay. So, and then coming to the second case, it seemed to be on MR imaging. There was a thickened optic nerve, so it seemed to me that seemed to be like what we are dealing with is a malignancy, and we could have gone for a whole body PET CT in that case to look for even any systemic focus. It did look to be, there was some, did seem to be malignant, didn't look to be benign at all. And so you went ahead with enucleation, but you had a positive margin, when the enucleation specimen was evaluated. So I think that would be an indication for external beam radiation, orbital radiation. So, but unfortunately, the patient was lost to follow up, so we don't have the outcome. what finally happened. Though once there is frank optic nerve invasion, the prognosis is, not so good.
So good. Thank you, Dr.
Thank you, Bhavna. So melanocytoma can grow, but if there's constant grow, which you can monitor with ultrasound or fundus photography, then it's probably a transformation into melanoma. There are a few more comments or questions. Sarah, Swati?
Just to comment perhaps briefly on both of the cases, not to take up too much time. I mean, I have seen a rare case of a malignant transformation of a melanocytoma to a melanoma at the optic disc. It was only diagnosed on the enucleated specimen. I have also received intraocular biopsies with the question melanocytoma versus melanoma, and it is exceedingly difficult. However, there are the typical morphology of the melanocytoma cells and the dense pigmentation, and requiring, therefore, more often not, a depigmented stain to identify the nuclei of the lesion. So that's just one for the first case. The second case, it is actually exceptionally unusual for a choroidal melanoma to infiltrate the optic nerve. I think there was a study undertaken in Denmark, and it showed that it was less than 1%. And when it does occur, it is usually associated with high intraocular pressure, and or a hemorrhagic necrotic tumor which forces the tumor cells down along the optic nerve. So it is really quite rare to see, and there's usually something else going on in the eye as well.
Okay, there's another entity to consider, which is rare, and that is adenocarcinoma of the RP. I recall one case from my fellowship in London. Amit, I don't know if you remember that. There was a case adjacent to the optic disc, which kind of it was in the differential. But it is extremely rare. Swati?
Yeah, thanks, Didi. So I just had one point to add, Purnima, for the question of how do you differentiate melanoma from melanocytoma. So just the clinical point, I thought I'll just add. If you look closely for melanocytoma, it has these feathery margins, while for a melanoma, it has very well-defined margins. That's a very subtle kind of difference between the two. But if you closely look at possibly all the melanocytoma cases that you would have seen so far, you will see that it has that feathery margins, which is certainly missing if it's a case of melanoma.
Thanks,
Feathery
Swati.
and also not so light, not so dark, maybe a lighter shade. Is that
Correct. Melanocytoma is obviously much more darker when you compare with the case of melanoma, unless there is retinal invasion that's occurring in a case of melanoma, which gives it that darker blackish brown color. Otherwise, yes, it's more of that brownish yellow rather than that blackish brown.
Amit?
Two thoughts. One is you could treat this with proton beam radiotherapy if there's no sign that there's posterior involvement, rather than having to nucleate the eye. They will lose their vision, but saves the eyeball. The other was more of a question to everybody in a way, is who monitors these? And we decided that these can be done by local ophthalmologists in the United Kingdom. It doesn't need to be seen by an oncology service if there's no change, because the risk is relatively so low of malignant transformation. So do people think it should be seen by an oncologist or general ophthalmology?
We can keep that an open question.
I think it's okay to keep it with the oncology part and we can do serial documentation as well. And comparative imaging will always help. So if we are taking the pictures every time the patient visits, it will be a good way to compare margin to margin and the exact elevation and the thickness as well. So I think to keep it with us would be a better choice than miss it and there's no room of error in our field.
Okay.
Thanks, Rolika. Martina?
I also wanted just to remember that sometimes you can have a visual loss in melanocytomas of the optic disc. just because of vascular compression. So with the larger ones, which are abutting the optic nerve head, we tend to do visual field to document that and also inform the patient so that there is not misdiagnosed as tumor progression by invading the nerve. So that it is an issue which can happen, the progressive visual loss due to that, and it doesn't mean malignant transformation. And as Amit said, we also tend to follow them for a while, but then move them on to secondary level retinal clinic cases which are stable, because otherwise the workload becomes impossible. So we share the follow-up. So we still see them from times to times, especially larger ones, but otherwise they can grow slightly, and still again, there's not a malignant transformation. Malignant transformation is really a complete transformation of the melanocytoma. What we did see, because we receive them for proton treatment sometimes, is misdiagnosis of actually peripapillary choroidal melanoma, which were initially diagnosed as melanocytoma just because they were close to the optic disc. But then when you look carefully, you see the choroidal base was always there. So that was grow, and there will always be basically a melanoma to begin with. So that is challenging sometimes, is the misdiagnosis of the opposite sense.
Thank you, Martina. So thank you, Purnima and Bhavna and everyone for the case and discussion. I think we're done. For some of us, it's already tomorrow. Peter. Okay. Any concluding remarks? Rolika, Sarah, Ganga?
No, it's
Ganga,
thank you
say
very much
something.
for inviting me to join. It's been fun.
Thank you, Sarah, for really accepting our invitation. Just a few points I wanted to make. First, compliments and congratulations to the 98 plus 25 people who are still hanging around 3.5 hours later. So I think kudos to the people who are hanging around, and of course, kudos to the brain behind it, Didi and Dolika, Santosh. I think the message we need to get across is ophthalmic oncology is a distinct specialty. Yes, we are all the converted, or we at least know there are cancers in and around the eye. But the message to each of us is in our own countries and region is to kind of emphasize to our residency programs that oncological conditions should be considered in the differential diagnosis of almost anything and everything that they see. And when in doubt, they should probably go to escalate it to whoever the authority is, number one. Number two, I also realized that there are several centers in the world, still they don't have a go-to person. And when we ourselves are sometimes confused between melanoma as melanocytoma as oncologists, so Amit's suggestion of UK where they decentralize everything, I think it's fine, practical. But when it's in doubt and there's both medical and medico-legal liability issues, then I think it's better off in the hands of the oncologists, no matter how busy they are, to have a reassuring hand. The third point I wanted to make across was ethnic variations. There are certain conditions more common in the Caucasian population, certain conditions more common in the East Asian population and the South Asian. And I think anything we see has to be seen with a little bit of context, but never ever work doing oncology without a reliable pathologist, without a reliable radiologist. And when in doubt, revisit your diagnosis. So, I mean, those are the few points, Didi. Sorry, I had to take a few extra seconds to drive home those points.
No, I knew you were the right guy to summarize. I don't have anything to add. I'll just say thank you to everyone, to the presenters, panelists, moderators, and all the attendees. Was very educational. I enjoyed it very much. That's it. Hope to see you soon, either in person or online. Thank you.
Thank you, everybody.
Okay.
Thank you.
We
Bye-bye.
have the
Thank you for
recording
your hard work.
and we
Thank
can
you.
share that. So, okay. Thanks very much.
Thank you.
Thank
Happy
you.
Valentine's
Bye-bye.
Day to all.
Bye-bye.
Thank you all.
Bye-bye. See you next time.
Bye. Bye.
Happy Valentine's.
Happy Valentine's.
Bye bye.
Bye.